All right. Good. Still morning. I'm calling this public roundtable to order. Today is Wednesday, July 8th, 2026. We're in room 123 of the John A. Wilson building. The time is 11:35 a.m. I'm at-large council member Christina Henderson, chair of the Committee on Health. Today we're holding a roundtable on the state of maternal and infant health in the district. The mayor's FY27 budget proposal included over $3 million of cuts to maternal and early childhood public health initiatives and interventions, with no new proposed investments or strategies to improve maternal and infant health outcomes. This came even as the most recent perinatal and infant mortality report from the DC Health shows concerning trends for certain key maternal health metrics between 2018 and 2024, including increases in severe maternal morbidity rates, marijuana use rates in pregnancy, and preterm birth rates. The district has a substantial role to play in perinatal health, as 43.4% of district births in 2025 were funded through Department of Healthcare Finances, Medicaid programs, or Alliance. The Committee on Health held a roundtable in December of 2023 on maternal and infant health, at which the executive highlighted efforts to improve health outcomes here in the district. Since that roundtable, the council has also passed several bills and made investments aimed to improve maternal and infant health. Today, we will discuss how the executive and the council-driven efforts have been rolled out through the district and what additional improvements must be made to meaningfully increase access to pre- and postnatal care, address the maternal mortality rates, and ensure healthy outcomes for district residents who are birthing children. We will also hear from maternal health professionals, including doulas, midwives, OBGYNs, and more, about their experience on the ground ensuring safety and health of expecting parents and infants. We haven't been joined by colleagues, although I know some of them are in the building as there are other hearings that are going on, but we'll certainly welcome them if any of them join. We are going to turn to our public witness testimony. All of our public witnesses will have 3 minutes to testify. You're welcome to submit longer written testimony for the record. Please be conscientious of your time. I'm going to call the first in-person witnesses, and then we'll go to our virtual folks. So, Crystal Jackson from A Queen Mama Doula Services, Leah Castles from Children's Law Center, Rodrigo Stein, there he is, from La Clinica de Pueblo, and Dr. Kate Sugarman from Doctors for Camp Closure. Ms. Jackson, when you're ready. Oh, yep.
Good morning, Chairperson Henderson and members of the Committee on Health. Since first testifying before this committee in 2023, I've gone from identifying barriers in the Medicaid doula benefit to helping implement it as a Medicaid provider and the district's doula equity consultant. There are 4 things I hope you remember today. 1, the Medicaid doula benefit exists, but implementation is incomplete. There are challenges at every step that have not been corrected systemically since the benefit was released. Doulas continue to struggle with enrollment, credentialing, billing, and reimbursement. 2, community-based organizations have been doing the implementation work. Through the Doula Learning and Action Collaborative, an interdisciplinary group grown from the Ward 8 Health Council's Maternal Health Working Group, approximately 60 doulas have been supported with technical assistance, peer learning, and systems navigation. This work has been funded through short-term grants rather than sustained public investment. 3, the Medicaid doula implementation infrastructure is a maternal health investment. Creating a benefit was only the first step. If the district wants the Medicaid doula benefit to improve maternal and infant health outcomes, it must invest in the organizations that help providers successfully participate in the program. 4. I urge the council to invest in community-based, doula-led implementation organizations that have demonstrated the ability to build and sustain this workforce. We should not rely on temporary grants to support an essential part of the district's maternal health strategy. Policies are designed in government, but they succeed or fail in community. Don't forget your doulas in implementation. I'm submitting more detailed written testimony describing my experiences and expertise. Thank you for the opportunity to testify. I am Crystal Jackson, a member of the Ward 8 Health Council and co-chair of the Maternal Health Working Group, a DC Medicaid doula provider, and the district's doula equity consultant, meaning I work at the intersections of maternal health, workforce development, and Medicaid systems transformation. Thank you. Welcome any questions.
Thank you. Leah? Leah, before you start, you go ahead and move the mic closer to you. There we go.
That's good. Okay, perfect. Good morning, Chairperson Henderson and staff. Thank you for the opportunity to testify today. As I reread Children's Law Center's 2023 Maternal Health Roundtable testimony, I was able to reflect on some positive steps forward for maternal health in the district. For example, a 2025 report from DC Health looking at 2019 to 2023 data found improvements in key perinatal health indicators, including decreases in rates of teen birth, preterm births, low birth weight, and infant mortality. The district also has two very engaged agencies in this area, DC Health and DHCF, who've taken initiatives to seek federal funding, like the Title V Maternal Health Block Grant and the Transforming Maternal Health Model from CMS. DC Health and DHCF have been partners in this work. They are responsive, and they invested time in working with community groups. We share many of the same goals and are able to work together to achieve them. Despite continued partnership and some improvements, we still have significant concerns that disparities in perinatal outcomes persist across racial and geographic lines. These concerns arise from client experiences and anecdotal evidence shared from partners working in maternal health, but not in concrete, up-to-date data. For example, Cedar Hill's opening offered significant hope for families in Ward 7 and 8. However, we have no data or reports on birth outcomes from the hospital's first year of operations in this space. Without consistent, clear, accessible, and well-analyzed data across maternal health, we are left with more questions than understanding. For example, despite having a doula Medicaid benefit, we continue to have limited access to doulas for Medicaid beneficiaries. Recently at Children's Law Center, we had a client in need of doula services who was enrolled in HSCSN. There was only one doula for us to reach out to. Fortunately, they were available, but if not for that one doula, our client would have had to navigate their birth without this support. Having the doula Medicaid benefit is not enough. There is a need for implementation support. We are therefore proud to lead the Doula Learning Action Collaborative along with the Queen Mama Doula Services, where we are directly working on filling in these implementation gaps for doula benefit, including working with DHCF and MCOs in the district to provide trainings to doulas on enrollment, credentialing, and billing. The complicated process to even become a doula is why we are extremely supportive of streamlining Medicaid credentialing. Additionally, sustaining the DLAC's implementation efforts is critical to ensure there remains an entity working on tangible implementation efforts of the doula benefit. We therefore would advocate for the creation of a hub to support doulas and other non-clinical workers like other jurisdictions have implemented. The hub can also address other areas of focus like reimbursement rates, doula hospital friendliness, and beneficiary outreach. Ultimately, this roundtable is an opportunity to take stock and strategize as the district prepares for both executive and council administrative changes. We would love to see the committee prioritize supporting non-clinical staff being integrated into the Medicaid space with a focus on implementation. My written testimony will go into greater detail, including programs like Healthy Steps, Perinatal Mental Health Task Force, and home visiting. Thank you for the opportunity to testify.
Thank you. Rodrigo?
Good morning, Chairperson Henderson, council staff, and members of the Health Committee. My name is Rodrigo Stein, Director of Health Equity and Strategic Partnerships at La Clínica del Pueblo, an FQHC serving thousands of predominantly Latino families in Washington, D.C. Thank you for the opportunity to testify today. This year, La Clínica completed a perinatal community health needs assessment that brought together patients, frontline staff, and health system partners to better understand what is preventing healthy pregnancy and healthy births in our community. And what we heard was clear. The greatest barriers facing pregnant and postpartum mothers are not simply medical, they are social and structural. Women describe navigating pregnancy alone, experiencing high levels of stress, financial insecurity, gender-based violence, and difficulty accessing culturally responsive care. Our own patient data reinforces these findings. More than 1/3 of women reported limited social connection, nearly 4 in 10 reported moderate to high stress, and almost 1 in 10 reported living in fear of a current or former partner. These challenges underscore the importance of continuous access to healthcare. When women lose health coverage, they are less likely to receive prenatal care, postpartum follow-up, behavioral health services, primary care, and care coordination needed to connect them with essential social supports. That ultimately leads to worse outcomes for mothers, infants, and our healthcare system. La Clínica is deeply grateful to the Council for lifting the moratorium on new DC Alliance adult enrollment, restoring some behavioral health supports, and investing in healthcare access for our communities. These actions will make meaningful differences for thousands of district residents and demonstrate the district's continued commitment to health equity. These investments are particularly important because maternal health disparities continue to widen. According to DC Health's Perinatal Health Report 2019 to 2023, pre-pregnancy diabetes among Latina mothers doubled over a 4-year period, while preterm births increased by approximately 30%, the largest increase among any racial or ethnic group. At the same time, providers like La Clínica are doing our part. Using the findings from our needs assessment, we're launching a redesigned culturally responsive perinatal care model that integrates behavioral health, social needs screening, case management, community health workers, peer support, and stronger care coordination between prenatal, postpartum, and pediatric care. Our goal is not simply to provide prenatal visits, but to build a system that supports mothers before, during, and after pregnancy. Community health centers cannot address these challenges alone, though. But with strong partnerships and sustained investments for FQHCs and community health centers, we can significantly improve maternal and infant health outcomes across the district. Thank you again for your leadership and continued investment in community-based healthcare. La Clínica looks forward to partnering with the district to ensure these important investments translate into healthier pregnancies, healthier families, and healthier communities. Thank you, and I welcome any questions.
Thank you. Dr. Sugarman,
Hi, good morning, council member.
you got to turn your mic on. There you
There
go.
we go. Okay. Good morning, council member Henderson and the committee and the health committee. I'm here as a primary care doctor. All of my patients are low income, mostly patients of color, and suffer all the health disparities that we've been discussing. I'm here to advocate for maternal health by opposing the closure of the postpartum unit 5F at Washington Hospital Center. A council member, as you mentioned in the introduction, in the District of Columbia, we have increased morbidity and mortality of our pregnant and postpartum patients. But we have the answer to this problem. It is the well-functioning labor delivery and postpartum units at Washington Hospital Center that we should be strengthening rather than eliminating. African-American women right now make up 90% of the pregnancy-related deaths, despite being only 50% of the birthing parents in our district. So we already know the problem. We already know the answer to strengthening a well-functioning program. I'm an organizer. I'm a family doctor. I'm organizer with the Keeping DC Healthy Coalition. We know how acute a crisis is for hospitals, and that we have to strengthen and increase their funding rather than closing down postpartum beds. Now is the time to increase rather than cut support for maternal health care. It means keeping our postpartum unit open and pressuring MedStar not to respond to budget pressures by cutting vital patients' care. As a doctor, I know firsthand that prepartum, postpartum in a woman's life is the most medically dangerous period of her life. And this is complicated by the increased rates that these patients have of gestational diabetes, of high blood pressure during pregnancy, which then puts them at risk and actually happens that they develop preeclampsia and eclampsia, and then untreated or improperly monitored, this has a high rate of leading to seizures, permanent disabilities, and death. So we have the opportunity to monitor these patients closely in the postpartum period so that they don't die from a preventable death. And these deaths also include blood clots, which happens in the postpartum period, again, needs to be monitored for. This will have a disproportionate, these bed closures will have a disproportionate impact on my patients, their families, if a child is left without a mother. And I ask the council members to please put pressure on MedStar, help us keep the postpartum unit open, make sure that MedStar is fulfilling its obligation to give 3% of its care to charity patients. Right now, it's only doing 1%. Please rally the community basis, and we're here to keep these beds open. Thank you.
Thank you. Thank you so much to this panel of witnesses. Heather, can you put me on a 7-minute clock? Just keep myself honest. Thank you so much to this panel of witnesses, and just for your overall dedication to the public health of district residents, and also our visitors. Okay, Ms. Jackson, I'll start with you. Both you and Ms. Castle sort of brought up the need for some additional support in terms of doula implementation. Ms. Jackson, you talked about there have been community-based organizations that have been supporting doulas with technical assistance via grants. Can you say a little bit more about, if you can, what type of grants? Like, you said they were time limited. So like, are they outside? Are they private grants? Can you just say a little bit more about that?
Yes, so a nonprofit organization, the Institute for Medicaid Innovation, offered a 3-year grant for multiple states across the nation to do doula implementation work. And so DC has that. We're halfway through year 2 and working on year 3 next year.
Okay.
Mhm.
And I know that both you and Leah have raised some issues in terms of the credentialing process. As you know or may know, we do have legislation that's currently pending before the committee to streamline the Medicaid credentialing. Um, while we had strong desires to move forward, we just know that Department of Healthcare Finance was going to be going through a lot next year in terms of the transition with some of the federal requirements. But that does not mean that we don't plan to move forward, but we just have to sort of pace things in time, and hopefully the streamlining of credentialing can help. But I do want to ask, just in terms of overall numbers, do we have enough doulas certified in the district to even begin to meet the need?
Definitely. They're certified, but we can't credential with healthcare finance. That's the issue. That's the bottleneck from step 1. So we can't
Okay.
even get to serving families if we can't credential as DC Medicaid doula providers.
Okay. Is it most people just not being able to sort of navigate CMS Medicaid speak to even begin that process? Like, if you have your certification, if you have your business license, if you have those pieces, I'm curious, like, is it a paperwork challenge or just a time challenge?
It's a mixture of both. So, for example, we hosted about 5 trainings to support doulas through just that step 1. Folks had to come back to multiple trainings in order to complete the process because one training that was about an hour and a half was not enough time to get it
Interesting.
done. Yeah.
Um, we sort of often talk about this in some of the other contexts of like, should there be a checklist? Is there a checklist of the like, these
We've
are the
created
documents that you
one.
need? What's up?
We have created one.
You've created one.
Mhm.
Okay. All right. That definitely provides a good resource.
Yes, it's definitely helpful, but even with having a program director from Maximus at those trainings to walk doulas through enrolling, again, doulas had to come back to multiple sessions to complete the process.
Okay. All right. Well, thank you. Thank you for being here. Mr. Stein, thank you for being here and for the testimony that you've provided as well. Some of the information that you talked about is a little bit similar to what Leah was sort of saying around like the importance of data in this context, because you brought up some things in the data report. I think you were talking about preterm diabetes amongst Latino women. And that's not normally and often an indicator that people talk about, right? Diabetes as part of it. But as you guys know, right, the having diabetes and also being pregnant can lead to other types of risk within the pregnancy. Do you all feel like as a clinic you're getting enough information or that there are enough feedback loops such that if you guys are seeing trends when folks are coming in for their prenatal visits, that you can like share that information with others around what's happening?
Yes, absolutely. And part of the reason that we conducted this needs assessment is we're redesigning and relaunching our perinatal care model. This is a response to transition and leadership, but also to improve the care that was being provided. So we'd be happy to share that data with other providers, specifically what's going on with the low-income Latino community, as specific trends that the community told us are being reflected in the patient data. And we know how those social drivers of health have downstream effects on health. So I'll be happy to share with the committee.
That would be super helpful, because one of the things that has been a frustration for me since being chair of the committee is that like a lot of our maternal health data lags behind by so many years. And so like the last time we did a roundtable on maternal health, sort of hearing from providers that like we're seeing an increase in trend in terms of substance use and marijuana usage and pregnancy. Well, that wasn't showing up in the data that we were getting from DC Health yet because that was a couple of years behind. So it's like, okay, if we're always getting our information 3 to 4 years after the fact, how do we address the crisis in the moment? And so this is super helpful that you're kind of going through this process in terms of the need assessment piece. Dr. Sugarman, thank you so much for being here as well. We have some folks from MedStar who are testifying later in the hearing. I've had a conversation with MedStar. I think this is one of the interesting things that I don't know if we've all sort of come to terms with in terms of public health, but we're going to have to think about, which is the trends of there are just less babies being born, right? Less women getting pregnant, less babies being born. And so what do we do about the infrastructure that we have built for a different time when there were lots of babies and all of those things? And how do we allow for institutions, whether it be clinics or otherwise, to adjust to the new volume without threatening patient care?
Well, it's a great question, but there are times that MedStar solution, because, births are cyclical and you might have a quiet week and then you'll have you'll have a very busy week. And
Yeah.
so MedStar has been like shipping postpartum mothers to St. Mary's County in Southern Maryland, which is really, really far away, or Georgetown, which also doesn't work for this, disadvantaged population. So they need to, literally not throw the baby out with the bathwater, right? Because they need to have enough beds for when the census is high, but then not, do what they've been doing, where shipping people out to St. Mary's County or to Georgetown or to into Baltimore. So there are times that the census is still high. So eliminating postpartum beds cannot be the answer unless we want our statistics to get even worse.
Correct. And I don't. I'm just trying to figure out, like, to your point around the flexibility in terms of census, how do we provide institutions with the flexibility such that you don't have a unit of 30 open and without anybody there? Does that make sense?
Yes, and I'm sure that the other hospitals have figured this out,
Yeah,
what
yeah.
to do when census is low, how to make use of the beds or whatever without closing the beds, so that our statistics will get even worse and more women will die from eclampsia or things like that.
All right. Okay. Well, thank you guys so much. If you haven't uploaded your testimony, please make sure you do so. Thank you. Okay, our next panel of in-person, Dr. Rochelle Logan from the DC Primary Care Association, Shanita Edwards from OABB. Oh, Abby. Okay. I mean, I didn't, everybody has different names for their acronyms, so I didn't know. I didn't want to make assumptions. Oh, Abby, Natural Hearing. Okay. Tambra Stevenson from WANDA. All right. Women Advancing Nutrition, Dietetics, and Agriculture. And Corinne Golston. Great. All right. Dr. Logan, when you're ready. No, it's not on. Now it's on.
Good morning. Thank you for the opportunity to provide testimony as part of the Roundtable on Maternal Health. My name is Dr. Rochelle Logan, and I am the Chief Program Officer at the DC Primary Care Association. DCPCA represents community health centers that serve approximately 180,000 people, including 1 in 5 district residents in every ward in the city, and over 4,500 prenatal patients just last year in 2025. DCPCA drives collective action to sustain health centers and their impact on transforming care. Our vision is that every resident in every DC community has access to high-quality preventative primary health care. The March of Dimes 2025 report card provides all the information policymakers require to understand the urgent need to act. We must use every available tool to change the course of the maternal and infant health outcomes. Despite attention and effort by providers, policymakers, advocates, and families, the district worsened on every measure tracked in the report. Our written testimony contains recent data from DC Health focused on concerning trends in births to teens, as well as persistent and growing gaps in outcomes between mothers. To highlight just one statistic here, the preterm birth rate shrunk by more than 10% for white mothers between 2019 and 2023, but grew by 18% and 23% for Black and Latina mothers, respectively, showcasing why infant mortality rate for Black mothers is nearly 5 times as high as that for white mothers. Our residents deserve better, and we can do better by leveraging tools that support close and consistent monitoring of conditions that put the health of birthing people at risk for adverse outcomes. By resourcing capacity to track blood pressure and glucose, we can better manage hypertension and diabetes during pregnancy and postpartum. We can intervene early to protect health and well-being of mothers and babies. District policymakers still have opportunities to help support, and DCPCA urges district agencies to implement the following remedy specific to pregnancy and postpartum coverage. Authorize community health centers to certify presumptive eligibility for pregnant patients. Health centers already support patients in the application process for health coverage, and we are confident that they can meet the standards for presumptive eligibility authority. Failure to implement these policies may lead to continued increases in low birth weight, preterm births, maternal mortality, and infant mortality and morbidity. Thank you.
Thank you. Ms. Edwards.
Greetings, Chairperson Henderson and members of the council. My name is Shanita Edwards, and I'm the founder and CEO of OABI Natural Healing, a Ward 8-based nonprofit providing culturally responsive doula care, holistic wellness education, herbal support, community-based maternal health services, and end-of-life support. I am honored to testify today on behalf of my ancestors and future birthing families of east of the river, also in partnership with the Ward 8 Health Council. OABI believes that improving health outcomes in the Great Ward 8 requires more than adding another program. It requires building a coordinated system where residents no longer have to navigate disconnected services on their own. As a second-generation Washingtonian, I have lived in Ward 8 most of my life. Every day, families in Ward 8 face barriers that begin long before expanding their families. The same issues I've witnessed and faced growing up: housing instability, food insecurities, chronic stress, limited access to culturally responsive care, and fragmented health systems all contribute to poor maternal and infant outcomes. These are not failures of individual families. These are systems that have failed us. At OABI, we see firsthand that birth is often the first opportunity to break the curse and interrupt generations of health inequities. When mothers receive continuous support before, during, and after birth, families are healthier, babies have stronger starts, and communities become more resilient. I just started to see small changes in Ward 8, and we owe it to the residents to keep the momentum and assist with implementing systems I didn't see growing up. OABI stands for Overcome Adversity and Become a Better You. Our work aligns closely with Ward 8 Health Council's vision and improving health across the entire life course, starting before conception for Black mothers, affecting their babies to children, tender teens, active adults, and seasoned residents. We hold the shared goal of increasing the life expectancy in Ward 8. As a community-based birth organization, OABI contributes by expanding maternal health education, connecting families to trusted resources, and ensuring residents with lived experience have a voice in shaping the systems that we serve. Today, I respectfully ask the council to continue investing even more resources in a comprehensive healthcare ecosystem east of the river by providing sustained support for Ward 8 Health Council and organizations like OABI that are doing the work alongside residents every day. When we invest in doulas, we invest in mothers. We invest in the children and families as a whole. Together, we improve the future health of the Great Ward 8, along also highlighting the doula support needed for incarcerated mothers giving birth while shackled. I give thanks for your time, your leadership, and commitment to our community. I look forward to continuing work together. Don't forget to owe Abby and all that you do, overcome adversity, and become a better you. Thank you.
Thank you. Tambra.
Good afternoon, Chairwoman Henderson. I'm Tamara Stevenson, founder and CEO of WANDA, Women Advancing Nutrition, Dietetics, and Agriculture. I serve as the health chair for NAACP DC branch, formerly on the DC Food Policy Council, a member of the Tufts Food and Nutrition Innovation Council, and Milken Institute Food as Medicine Advisory Board. The last time I spoke in front of the council was urging the expansion of doula services east of the river, seeing the facing reduction of labor delivery services, yet the more birth babies in the district. So I want to build on that conversation by highlighting another essential part of maternal health that deserves greater investment, which is access to nutrition and community partnerships that make healthy pregnancies possible. The issue is quite personal. As someone who birthed 2 babies, needing Community Hope Birth Center and Washington Hospital Center when I had emergency C-sections. But my nutrition background greatly benefited me from having healthy babies. And families need a full continuum of options from community-based prenatal support, birth centers, and hospital-based specialty care. And a healthy pregnancy is not created during birth, but before conception, and continues well in postpartum period. Yet nutrition remains one of the least integrated components of maternal health beyond WIC. Despite its influence on gestational diabetes, hypertension, anemia, as my colleagues have mentioned. Last fall, WANDA piloted Nourish Maternal Food as Medicine in east of the river to help with access to trauma-informed, cultural, meaningful culinary nutrition education support, grounded in lived experience in partnership with Dreaming Out Loud, training birth workers as those who testify today, serving our families in DC. And we found that the doulas and community health workers and other trusted professionals are eager to receive cultural relevant nutrition guidance to support clients, but they need sustainable support, evidence-based training, and strong connections to the healthcare system. The Milken Institute Feeding Change Initiative has shown that community-based organizations are essential partners in food as medicine because they build trust, improve partnership, bridge the gap between healthcare systems and everyday life. And if we want healthier babies and pregnancies, we must not only invest in clinical care, but in trusted organizations that help families put healthy practices in action. So as the district evaluates maternal health investments, I encourage the council to view nutrition as a core infrastructure, not an add-on option. We should invest in CBOs that provide cultural responsible nutrition education, strengthen the partnerships between providers and organizations. Finally, I want to respectfully ask that DC Health and Healthcare Finance with the following questions. How is the district incorporating food as medicine into maternal health strategy? How are CBOs being supported as implementation partners? And how will the district measure these investments are improving outcomes for moms and babies, especially east of the river? Because the first food of medicine for a child is through the mom, and healthy moms require more than health care, but nourishment, trust, and community. When we invest in all three, we give each child a healthier beginning and every family a strong future. Thank you for the opportunity to testify.
Thank you. Corinne. Oh, got to turn your mic on. There you go.
Hello, my name is Corinne Golston. I am a nurse at Washington Hospital Center. I have worked there for 7 years, the last 3 as a labor and delivery nurse. I am also a shop steward for the National Nurses United and a student of midwifery and women's health practitioner at Georgetown. I am here to advocate for maternal health by opposing the closure of a postpartum unit 5F at Hospital Center. 1 in 3 babies are born at Hospital Center that are born in the district. We are the trusted delivery site for 3 of the 7 district federally qualified health centers, and our physical connection to Children's National allows us to have their doctors, surgeons, nurses, medical transporters, and specialty equipment in the room with our babies as soon as they're born. They're also able to be transported to the children's ORs and as well as their specialty units within minutes without being at the whims of DC traffic or weather. Something else that I am personally very proud of being able to deliver as a district nurse is the time and care for people who do not get to take their babies home. The district is a hub for access to abortion care, and we have patients from all over the country come to Hospital Center so that they can grieve their children in a timely manner. Without postpartum, I do not have a place to put the mother who has to grieve. I do not have a place to put the mother who needs to have their baby. I will not have access to ORs because they're being used for vaginal deliveries because we could not put our recovered and antepartum patients at our postpartum unit. Everyone deserves dignity in their delivery as well as privacy. Laboring inside assessment rooms, triage rooms, operating rooms, and hallways is not an option. When we asked MedStar what was their plans for mitigating the effect on our community with this closure, they had told us that we will be relying more on other facilities in the health system, particularly Georgetown and Franklin Square. This is not an option for most of Washingtonians. They also had said that they were starting to help Cedar Hill bolster their women and infant health services. Cedar Hill has recently celebrated their 100th delivery in their first year of being open. Hospital Center averages 200 to 250 deliveries a month. Aside from this, we were given platitudes of how it will be good times, there'll be bad times, there'll be roses, there'll be thorns. Today, I ask the council to please put pressure on MedStar. Please help us keep our postpartum unit open. Please help make sure that they fulfill their obligation of 3% of charity care, which as one of the doctors earlier had said, they're only fulfilling 1%, and also to rally your community bases. We also ask for those who are here today or listening later, please follow union nurses at MWHC for how the community can get involved in this issue, as well as we'd like to thank the healthcare workers that are here today for fighting the good fight and the council for inviting us. Thank you.
Thank you. Thank you so much to this panel of witnesses. I want to follow up on a couple of things. Ms. Stevenson, you talked a little bit about a program that you guys did in partnership with Dreaming Out Loud.
Yeah.
How many participants did you all were able to have for that?
Yeah, we were successfully recruited 20 applicants for that program.
Okay. How long, I know you were time constrained, so I want to ask if you could say a little bit more about
Most definitely.
what you all did and what were some of the outcomes that were observed.
Most definitely. So we did conduct an impact report for internal use, and we'll be presenting at the Society of Nutrition, Education, Behavior, and Black Mama Matters Alliance health training conference in Atlanta in September. From that intervention, it was over a course of 4 weeks. We had every topic from gestational diabetes to hypertension, also case-based studies rooted in DC communities, so Ward 8, and also providing resources to those attending. Many of them were birth workers who had day jobs. And so we conducted it in the evening at the Marionberry Market before it launched. We had a registered dietitian, also a mom, chefs who are also moms who could talk from their lived experience. We incorporated African diasporan foodways, Caribbean, African-American recipes. We had them participate and actually conduct the recipes as well so they can gain their own kitchen confidence, being able to help replicate these menus with their patients. And for many who were birth workers and also food providers, it helped to enhance and build their own confidence. Many of them in our baseline said they had no to low nutrition education, and with the cost of academic training and student loans, we know that nutrition is cost prohibitive for many folks. And so being able to democratize education, providing it in community and safe spaces, we were told they would love to do it again, which we're looking to bring it back this year. But again, it takes funding, and we relied on Dreaming Out Loud to help cover those costs, give scholarships to make sure that no one had to take any money out of their pockets. But we did know they would have loved and would have paid for it if we did put a price tag on the program as well. So we're taking their data, doing both pre-post testing and interviews to help expand and make a more robust, longer program that's also hybrid, in-person and virtual, in order to meet them where they are. We did allow them to bring their children, which only added value to show this is why we're here to do this work. And so we say no mom should ever apologize for bringing their children along, because it helps to make a more rooted, grounded, and robust experience of why we do this work every day.
Yeah. Well, that sounds great. It also kind of reminds me of once upon a time before the Republicans took over, there was this program called SNAP Ed,
Yes, it
which
was an FNF educator.
yeah. So it sounds like you guys are sort of picking up and also kind of expanding to
Yeah.
this very specific population, something that used to be federally funded. And I think are super helpful to the point that you said, like, nutrition is helping make healthy babies. It's core, not an add-on. And more work needing to be done in that arena. Just in terms of helping people make healthy choices. I don't know. Yesterday I ran to Pret after what was too long of a meeting in this building. And I didn't have my water bottle, but I was thirsty. I was gonna sit there and eat. And so I was like, okay, let me look at the options. I could get the lemonade for $5.49,
Right.
or I can get the 12-ounce can of Coke for like $3, which is expensive. And I was like, this is just, the lemonade is clearly the healthier option, but it is also the most expensive option, such that we're just pushing people into, you know,
Yes,
the,
it is a system designed, and that is why we have to incorporate nutrition professionals in a part of this maternal health conversation, which many of times we have not been a part of the process. It's critical that we're part of the policy making process, because from the maternal health policies I've seen, they have very light watered versions of what nutrition truly means. We're more than a cooking demo. We're trained literally one class away from being a chemistry minor. And so for us, it's equally as important to understand, just as much as we need a doctor, we need someone who also knows how to grow the food, but could cook and not cook out the nutrients in the food, and understand how do we make sure that families feel comfortable when they get the food, prepare it, and if they can't, how do we train those who are the culinary and birth worker professionals to make sure they can provide that support for those families. Because in the end, we may not be the hard savings that is apparent, but we are the soft savings in the beginning when we think about what public health means. And having been a former extension agent at University of District of Columbia, that is where I cut my teeth of understanding being like the Mary Poppins in nutrition, being in childcare centers, in housing authorities, in schools, in senior centers. That is the most fundamental experience that helped me to understand we are not simply telling folks what they already know. We're helping to say you are worthy, you're deserving, you are valuable to eat the foods to make a healthy body, to live your God-given purpose. And people need to understand that basic decency of what it means to have culturally competent nutrition educational professionals, and training those to be the next generation to follow in our footsteps.
I want to leave it there, but I do need to ask some additional questions.
Yeah.
But thank you. Thank you for your passion, and thank you for the work that you're doing. I love that the nutrition piece of our work in government is in the health committee, and sometimes that's a little weird for people, but
No, it's not.
there on purpose.
On purpose.
And it's something that we definitely focus on for sure. Ms. Golston, I wanted to ask, in your testimony, I think you brought up something that we don't often think about, which is what happens if someone isn't able to bring their baby home,
Yeah.
and the recovery piece there. But I just want to get clarification. So you said that patients who are recovering from those procedures aren't able to be on the postpartum unit? Can you say?
No, they are not. At hospital center, we kind of figured that having someone hear someone else's crying baby next door is kind of traumatizing. So we usually keep them on our labor and delivery unit for as long as they need. They oftentimes are medically cleared to go home, but emotionally they just need more time.
Yeah.
As well as navigating things like the meeting earlier was talking about burial procedures, navigating things like burial procedures, because no one has ever thought about how to bury a 28-week fetus. So we take our time, we let them grieve as much as they can before they have to start saying those really final goodbyes. And that just is something that we won't be able to provide as easily if I have to think about, well, I need her to get out of the room because I have 3 laboring patients in my triage, but she has been medically covered and everything like that, and she's just there grieving, which is an important part of their healing process.
Got it. Okay. like I said, we have some folks who are testifying from MedStar later, so we'll have some opportunity to follow up there. And I think the comparison in terms of the volume that you gave is pretty striking, right?
Yeah.
So Cedar Hill open for a year, yay, 100 births, woohoo!
It's just very impressive, and I'm proud that they are able to do that, but it's just,
And you're like,
they're
no,
not-
we do 200 in a month.
yes, we are the busiest hospital for women's health in the district. I think I had looked up statistics where comparatively in 2025, the estimated at least was almost like 40% of the babies, not just like the 1/3 that we had from beforehand.
Yeah.
It was about estimated 40% in 2025 were born at hospital center.
Okay. All right. I don't have any other questions. Thank you, Ms. Edwards, for being here, Dr. Logan as well. If we don't have your written testimony, if you could please provide it for the record. Thank you. Okay, we're going to go to our virtual witnesses. For those who haven't done virtual hearings with us before, you have to affirmatively accept our invitation to become a panelist. There'll be a little box that pops up on your screen, and you do have to click the button in order to become a panelist. We're going to do a panel of 6 because I have 11 people here, but I'm just going to assume that perhaps somebody might not join us. So Justin Palmer from DC Hospital Association, Jaren Hill Lockridge from Dreaming Out Loud and the Ward 8 Health Council, Antonio Myers, Elizabeth O'Donnell, Nandi Jinja, and Lauren Messinger from Mary Center. Okay, I'm going to give it just a moment for folks to join. Okay. The other thing that I need to mention is that we can't promote you if your name on your Zoom is like iPhone A or just 2 initials. You do have to like really tell us who you are. Okay. Justin, when you're ready.
Good afternoon, Chairperson Henderson and members of the Committee on Health. My name is Justin Palmer, and I'm the Vice President for Public Policy and External Affairs at the District of Columbia Hospital Association and a resident of Ward 7. Thank you for the opportunity to provide testimony at today's roundtable on maternal and infant health. DCHA is proud to lead the DC Perinatal Quality Collaborative, a multi-stakeholder partnership funded by DC Health and HRSA, dedicated to reducing maternal mortality, improving maternal and infant health outcomes, and narrowing racial and place-based disparities through quality improvement initiatives. The collaborative brings together over 250 stakeholders across the district's birthing hospitals, federally qualified health centers, community-based organizations, and other public health partners to improve the safety and quality of perinatal care. One of DCPQC's current initiatives is improving perinatal mental health. Earlier this year, we launched a year-long Alliance for Innovation Maternal Mental Health Safety Bundle, aimed at improving maternal mental health screening, education, and referral practices from the prenatal through the postpartum periods. This initiative aligns with the broader Transforming Maternal Health team-up model recently implemented by the Department of Healthcare Finance and is the first DCPQC effort to include hospital, outpatient, and community organization-based teams in adopting best practices. As the first year of implementation continues, the PQC is actively supporting participating organizations through technical assistance, education, and training on the reporting platform. To date, over 100 participants across 10 organizations have engaged in perinatal mental health implementation activities. The PQC also continues to make measurable progress in implementing nationally recognized maternal safety initiatives. Through the AIM Obstetric Hemorrhage Patient Safety Bundle, participating hospitals have increased the adoption of standardized quantified blood loss measurement practices and the documentation rates of recognition from 69.8% in Q4 of 2023 to 92.8% in Q3 of 2025. Use of quantified blood loss techniques has improved teams' ability to identify hemorrhage events earlier and initiate appropriate management and care teams. Beyond clinical quality improvement, the PQC is also expanding community education and prevention efforts. In May 2025, we launched Count the Kicks, which is an evidence-based program that teaches expectant mothers about the importance of tracking fetal movement and improves patient-provider communication to reduce preventable stillbirths. Since launching this initiative, DC has shown the strongest growth across all states implementing Count the Kicks, with an 83% increase in engagement among registered users. Building on this early success, DCHA is expanding the program's community footprint through additional investments from the collective community investment funds at DCHA. The additional funding we have allocated allows us to broaden outreach and strengthen partnerships with community organizations, prenatal care providers, and ensure that more expectant mothers have access to the educational resources through various public engagement strategies. The progress we have made reflects the power of collaboration and sustained investment in quality improvement. Together with DC Health, the PQC is strengthening systems of care, advancing evidence-based practices, improving birth outcomes for moms and infants throughout the district. Thank you for allowing me to testify, and I'm happy to answer any questions, and apologize for going 26 seconds over.
Thanks, Justin. Jaren?
Good afternoon, Chairperson Henderson and members of the committee. I'm Jaren Hill Lockridge, and I wear a lot of hats. I'm here in my role as Director of Strategic Partnerships at Dreaming Out Loud and the Ward 8 Health Council. And really, as a Black mother east of the river, I have firsthand experience navigating the complexities of our maternal healthcare ecosystem. And I want to also name something that's sometimes missing from these conversations, that maternal mortality is not just affecting mothers who we've lost, but it also affects the mothers who are still here as we make choices about our future. See, it's not always that we don't want to have more children or that we don't want to grow our families. Sometimes we're afraid that we might not survive the pregnancy and childbirth. And that's just really crazy, right? When we're forced to weigh the joy of having a baby and if we'll come home, that's more than just something that can be solved by a hospital solution. That is explicitly a maternal health crisis. And we need a complete ecosystem that supports women before pregnancy, through their pregnancy, during birth, after birth, and throughout motherhood. But I want to also acknowledge the progress that has been made. I'm so proud of the maternal working group and the way that they have showed up today and all the work that they've done. Shout out to some of those other stakeholders east of the river, for the city for investing in the Cedar Hill Regional Medical Center, which again allows us in Ward 8 to have a labor and delivery resource that we haven't had after way too long. So I commend the district for the work that they've done supporting doulas and to strengthen the collaboration across CBOs, providers, agencies, and the boots on the ground. But as Tambra said earlier, these investments are not enough. It's a step in the right direction, but we need to be clear in how we're supporting our mothers through food specifically. That's a mechanism for social cohesion. And we know that maternal food as medicine is a no-brainer. I can go on and on and on about the work that we do at Dreaming Out Loud. Y'all know how we at the Ward 8 Health Council stand on maternal health care, particularly for our mamas east of the river. So that's why I really want to encourage the city, the council, and everybody else to invest in maternal food as medicine initiatives east of the river specifically. See, we're trying to do something really cool by embedding it with doula support at Cedar Hill and Children's and all these other things. Tambra spoke to the work we did last year with the pilot of Nourish, providing nutrition education directly to birth workers in community. So really trying to build this partnership, this ecosystem, to wrap our arms around what it means to make sure that our mamas, particularly those east of the river, have all the resources that they need. So I can look forward to partnering with the council, DC Health, Healthcare Finance, GW, Cedar Hill, and anybody else to say that our zip code should not determine how long we live, nor should it determine my future grandchildren's ability to get to know their mama. So again, thank y'all for the opportunity to testify, and I look forward to any questions you may have.
Thank you. I don't see Antonio, but I do see Liz.
Hi, everyone. Councilwoman Henderson, members of the committee, thank you so much for this opportunity to testify today and for your continued commitment to improving maternal infant health here in DC. My name is Liz O'Donnell. I am a very proud Ward 8 resident and the founder and executive director of Aaliyah in Action, which is a DC-based nonprofit. We provide bereavement support for families experiencing any form of pregnancy or infant loss. And I also serve as the Count the Kicks DC ambassador, which helps implement evidence-based stillbirth prevention strategies so that more families can make it home together in a way that mine was not able to. I first want to recognize the progress that has been made with Count the Kicks that was actually just shared. So this program empowers expectant families to really recognize changes in fetal movement and seek care when something doesn't feel right. I personally would have greatly benefited from this had we had this program in DC while I was pregnant. And since launching in DC, thousands of education materials have been distributed. Hundreds of families have used the app. We know the resources are available in multiple languages, and the digital outreach numbers, when I looked yesterday, have reached tens of thousands of DC residents. One of the most encouraging examples that I was actually able to be a part of has been with Community of Hope Birth Center. Seeing their providers really embrace Count the Kicks has just showed what's possible when these healthcare organizations really invest their time in our evidence-based education. And I hope to see even more hospitals and prenatal practices throughout DC actively promoting this program, and I'm happy to help with that in any way that I can. When prevention works, fewer families experience stillbirth. But of course, we know not every loss is preventable. And so when a loss does occur, the quality of care they receive really truly matters. The US has no standardized perinatal bereavement framework, so care is very fragmented across systems, even here in DC. And after the stillbirth of my daughter, Aaliyah, I founded Aaliyah in Action to really help address that gap. We have bereavement packages that are available to all DC residents and are in almost every DC hospital and birth center. And due to provider requests, I actually just developed an accredited training program to help provide compassionate and anti-racist bereavement care. And so I would love to see DC, the city that my daughter should be growing up in, become a leader in helping to build standardized perinatal bereavement care, as sadly so many of our DC families need it. And the providers that are giving them this care need the knowledge and confidence to deliver that care to these families. Just real quick, after hearing the previous testimony, I really want to thank Washington Hospital Center for the amazing work that they do for families and for advocating for safe spaces post-loss, because I know firsthand how valuable that is. So really, my ask is simple: continue investing in stillbirth prevention through programs like Count the Kicks, and then also start considering how equitable bereavement care for families can also become a part of the maternal health conversations here. And then real quick, I mentioned that Aaliyah in Action is currently partnered with almost every hospital. Cedar Hill is the one hospital that I've been trying very hard to connect with and have not been so successful. So if anyone knows someone in the L&D unit there, please, please, please let me know, because I want to make sure that we support them if families do need perinatal bereavement care. So thank you so much for your time, and I'm, of course, open to any questions.
Thank you. Nandy? Nandy, did we freeze? Did you freeze? I don't know if she's.
Can you hear me? Am I still frozen?
We can hear you now.
Okay, perfect. Okay. Good morning, Christina Henderson and the members of the committee. My name is Zani Majinga. I am a mother of 4 years working to improve maternal health in the district. But today I am speaking as a mother. Please bear with me, as it took me 3 times to write this in a way that my emotions are clearly written to form the council to hear me. Having postpartum depression feels like a curse. You know what you have, you know why you are struggling, and you know what the research and data says, and evidence that's showing what postpartum depression and anxiety can do to a mother. Yet every day you are still expected to show up and act as if your struggles are not real, just to be accepted. Although I have advocated for myself has shown me how much work we still have to do. It feels like no one believes you. It feels like the data and history of Black mothers needing to show up while suffering on the inside gets overlooked. Like, no way Nadi is suffering. She is here. Not knowing it took me tears and breaths and God to be here. Even now, I struggle with my confidence. I have 6 weeks left before my unemployment ends, and I am terrified of finding a job that I can actually maintain while managing my mental health. The way postpartum depression affects memory, executive functioning, and concentration, everyday administrative tasks is really recognized or accommodated by the way it should be. Financially, the postpartum period has been overwhelming. I have a $7,000 bill from Sibley Hospital from giving birth to my daughter on February 19th. During pregnancy, even though I have access to SNAP, TANF, and new efforts to help parents thrive, I still struggle to maintain bills. I have lost my teeth. We know postpartum pregnancy affects oral health, yet mothers still told that dental implants are cosmetic rather than a medical necessity. I also was not able to access paid maternal leave after losing my job. Instead, I had to depend on unemployment much sooner than I should have, leaving me with very little time to recover before worrying about how I can support my family. I had the hardest part of my postpartum journey. Journey with the World Health Council for gifting me with my doula crystal and making sure I had groceries, and encouraged me when I could not no longer encourage myself, and even Crystal, who watched my 4-week-old daughter so I can attend my unemployment workshop to restore my unemployment benefits. Leah and Rakia at DCH reminded me who I am, as I felt like on days I felt like I had failed and could no longer show up for myself. Thank you. My midwives, Abney and Lauren, and Dr. Patel, and my care team at Community Health to continue caring for me beyond the traditional 6 weeks postpartum period, because they no longer knew I was ready to lose my relationships with them. Navigator Jamila, who continued to check on me even when I could not have the strength to answer the phone call. Chairperson Christina Henderson for helping me restore my electricity when my family lost power. Robert Wright's office, especially Jasmine, for connecting me with service when I could no longer get through my own. Help my family avoid eviction. As of June 25th, my family is no longer at risk of homelessness. The Department of Health for responding when I could no longer reach out to my network. And I sent one email blast, and they connect me to the right person in AmeriHealth, because I no longer could hear community resources say I had no more funding. Martha's Table's Baby and Me program, who continued to surround my family with care and remind me the whole person care. Every morning I listen to For Every Mountain to remind myself that God is still with me. My faith, together with the people God has placed in my life, remind me every day to keep choosing to be here. Even when I feel weak, some days simply put on clothes and eating a good meal or taking a small step reminds me that I am still capable. Recovery is not always big victories, but sometimes it's choosing to keep going. I have included several policy recommendations in my submitted written testimony, including expanding postpartum support to 1 full year, recognizing pregnancy-related dental care as a medical necessity under Medicaid, invested in workforce re-entry opportunities for postpartum mothers, expanding postpartum doula care, protecting parents who lose employment during their postpartum period, strengthening workplace accommodations for postpartum mental health conditions, and investing in fatherhood programs and building strong community-based family support systems that surround parents with a village before families reach crisis. Thank you for listening, and thank you.
Nandi, thank you. Thank you for sharing. Thank you. Seriously, thank you. Don't go away, but I know you got it. Take a deep breath. You got through it, and we appreciate you sharing. Okay. Lauren.
Hi, good afternoon. Thank you, Chairperson Henderson and members of the DC Health Committee for having us here today to speak upon such an important issue in our district. I'm Dr. Lauren Messenger, the Women's Health Clinical Lead at Mary Center, a community health center dedicated to providing equitable and comprehensive care to underserved populations in our city. Today, I would like to highlight several critical clinical issues impacting maternal health in our district. I'd like to start with the recent developments at MedStar Washington Hospital Center, which some people have already spoken about today. The pending closure of their postpartum unit is of a significant concern. While hospital officials have stated that this will not impact our ability to schedule C-sections and inductions and their ability to care for our federally qualified health center patients, the reduction in postpartum capacity will ultimately diminish overall labor and delivery resources. We already see multiple announcements each week that the hospital is on hold and not accepting new patients in labor. The closure can only seek to worsen those capacity limitations. We worry this will lead to increased strain on remaining facilities as well as barrier to timely and quality care for our birthing families. I'd also like to highlight a few clinical challenges that we are already seeing with the current changes in the last year that have negatively affected our ability to care for these women and their children and affected infant and maternal health outcomes. We've already seen insurance coverage gaps where we encounter numerous patients whose Medicaid insurance is inexplicably marked as inactive. This results in months of missed prenatal care. The lapse in care is hampering our ability to manage pregnancy complications such as diabetes and hypertension, both of which have long-term health consequences for both mother and child. Data from literature shows that the conditions in these conditions in pregnancy correlate with poorer long-term outcomes for children, including things such as diabetes, obesity, developmental issues, and cardiovascular disease. How we care for these women today is going to impact the health of many generations to come. We've seen alterations in medication access and formulary changes. These changes in Medicaid and insurance formularies have made acquiring essential medications such as insulin and supplies for blood glucose monitoring more difficult. We're seeing delays in treatment, which increases the risk of uncontrolled diabetes during pregnancy, adverse fetal outcomes, including fetal growth restriction and preterm birth. We've seen an increase in uninsured patients and their seeking of emergency care. Patients without insurance often end up in the emergency department for things that we can and should manage in the outpatient setting. These are costly to the healthcare system, provide fragmented care, and lack proper coordination. I would like to highlight one thing that I think we do really well at Mary Center, and we have an incredible dedicated social work team that helps our patients navigate these complex issues, connect them to resources, address social determinants of health, and facilitate access to care. We realize that not all clinics and facilities have this capacity, and they're not uniquely revenue-generating resources. But I do want to highlight the importance of funding for social services because it does help us ensure integral continuity of care and improving health outcomes. And I know I'm running over, so I'll just say that the stability and expansion of prenatal care and postpartum care services in the district is really essential for maintaining maternal health and child well-being. So I thank you for your attention and your ongoing commitment to maternal health in DC.
Thank you. Thank you so much to this panel of witnesses for your testimony and for your advocacy and your work. I'll start with Liz. When you popped up on the screen, I was like, I've seen you before. And then I was like, oh, okay, I remember. Because it was your advocacy that led to the committee funding Count the Kicks the first time. And so it was great to hear from Justin at the DC Hospital Association about the implementation, but also the decision to go further in expansion. So I appreciate so much your advocacy and continue work in this regard. Justin, I wanted to follow up with you. You talked a little bit about how one of the priorities for the PQC was around perinatal mental health. And in light of some of the later testimony, I was wondering if you might be able to expand upon how the hospitals are choosing to approach this.
So with the mental health bundle, the community involvement is essential, and that is through the PQC working with the outpatient and community providers is going to be essential to making sure that we have the resources in the network for prenatal postpartum moms. And so that has been a lot of the groundwork that has been laid. That is one of the reasons why the mental health bundle is challenging, but that is one of the reasons why it has been a priority for the PQC, and they have spent, starting implementation this year, but the planning for implementation, was a year before that to make sure that we were tracking everything that we needed to and making the connections. And we continue to do that as we roll out the program. And I can get more information and offer a particular briefing on everything entailed on that as a follow-up to the hearing.
Yeah, I mean, it would just be helpful to kind of know the issue is obviously complex and multi-layered. It shows in a variety of different ways, and sort of what are hospitals doing versus, say, what a clinic's doing, et cetera. That it would be just very helpful on that front. I do recall, though, one of the foci areas of PQC before was around preeclampsia. And hypertension, and I was wondering if you guys have any updated around the results from that previous work.
I don't have that with me right now, but I can follow up on that
Okay.
after the hearing.
Okay. I know that there's some things that I think in the prior conversations of like, it's just very systematic in terms of what hospitals can do. I think also there have probably been some additional, whether it's remote patient monitoring and some other tests and things like that that have been deployed that could help with a lot of this.
That and the hospitals, and we've been working with them to deploy blood pressure cuffs. So
Yes.
we've deployed blood pressure cuffs to all and continue to supply those to hospitals in order to make sure that they are being distributed as well.
Okay, thank you. Miss trying to decide where I want to go here. Well, Miss Messinger, first I'll say thank you so much for being here from Mary Center. I'm curious in terms of implementation on the ground. So, this current fiscal year, there were changes in terms of the Alliance Health Program. But we had made provisions available that if if a patient was pregnant, they were able to still be able to continue. Has that been happening in a somewhat easy manner, or have there been challenges in terms of that?
Yeah, I think we have encountered certainly some challenges where patients who were pregnant are still being told their insurance is inactive, and the paperwork and the process to notify Alliance that they are still pregnant is complex and has required our social workers, which again, we're lucky to have here, and have been great at stepping in to help our patients. But it has been a challenge, and I have called many a patient who's missed their appointment to find out why they weren't here, and it's an insurance issue 9 times out of 10 when I'm calling them. So we are appreciative of the provisions that are there, but there were some challenges in our patients being able to communicate and get the Alliance team to know they're still pregnant.
Okay. All right. We'll ask some follow-up questions to healthcare finance on that front. Nandy, again, I want to say thank you so much for being here and for sharing your story and being vulnerable to share your story. There are lots of different things that you talked about, and some of them that people don't necessarily think of, the dental piece being part of it. Sometimes when I hear people talk about like, oh, pregnancy, it's fine, whatever. And I'm like, there are all these other complications that can arise that don't have anything to do with the actual delivery or giving birth, but the impacts that it has to the health of the person who is carrying the child. But I think you mentioned this, but you said that lost teeth or dental related issues that is related to pregnancy is considered cosmetic and therefore not covered by insurance. Is that what you? Oh, wait, I think you froze.
Plants is considered cosmetic, so you can't get implants if you can't get implants. It's covered through insurance because it's considered a cosmetic.
Okay, even though we know what the cause was.
Right.
All right.
Because I've tried it.
Yeah. Okay, we'll follow up on some of these pieces. Thank you for being here. Jaren, thank you for the work that the Ward 8 Health Council does, because I feel like in this situation and in so many others, that network is truly helping to provide that additional support to community, especially when they're in deep need. And all the various folks that came together. I know it's not a one-off. I know it's something that you guys are doing often. So thank you so much. All right. We're going to go to our next panel of witnesses. Again, if you haven't provided your written testimony for the record, please go online and do so. So these are our last group of public witnesses. Laura Brown from the First Shift Justice Project. Amy Sawyer from Sibley Memorial Hospital, Johns Hopkins Medicine. Raina Smith-Jordan from Sibley Memorial, Johns Hopkins Medicine. Dr. Angela Thomas from MedStar Health, and Dr. Tamika Augusti from MedStar Health. I'll give them just a minute. Okay. While folks are coming on, Laura, when you're ready.
Good morning, Council, or afternoon maybe. Councilmember Henderson, my name is Laura Brown, and I'm the Executive Director of First Shift Justice Project. First Shift's lens for improving maternal and infant health is employment. We help clients request pregnancy accommodations and paid job-protected leave so they don't lose their jobs. Pregnant workers' ability to feed, house, clothe, and care for themselves and their babies is dependent on their economic stability. Workers' rights directly impact maternal health. Here are some examples of our clients. A pregnant worker with diabetes needed breaks to eat to manage her blood sugar. Her boss said she should just get a juice and keep working. Her request for breaks should have been granted as a reasonable accommodation. A pregnant nurse had a low-lying placenta and needed a temporary lifting restriction. The hospital's human resources department told her she had to take unpaid leave. She was the sole breadwinner for her multi-generational family of 4, soon to be 5, and could not afford to miss a paycheck. She found another doctor who cleared her for work against medical best practice and made her sign a waiver of liability. The hospital should have granted the lifting restriction. A teacher was told by her boss that she was not eligible for FMLA leave and could not take time off to recover from childbirth. Her boss didn't know that she had that right under DC's pregnancy accommodations law. DC has had this law on the books since 2015. How is it even possible that her boss did not know that? First Shift helped her avoid losing her job. Efforts to improve maternal and infant health must include consideration of employment and other social determinants of health. The Centering Pregnancy model of providing prenatal care is one such program. My medical colleagues will tell you that this is an evidence-based prenatal care program proven to reduce preterm births. First Shift works with centering groups at Community of Hope, Unity, and Mary Center to teach pregnant workers about their workplace rights and offer our legal services. Last year, we gave 17 presentations at Community of Hope alone. We can reach more moms in a meaningful way because of pregnancy centering programs. Another way to improve maternal health is to develop and support OBGYNs, doulas, midwives, and community health workers who have a deep understanding of the lived experience of their patients and a holistic approach to care. Finally, making DC paid leave benefits portable supports maternal and infant health by allowing pregnant workers to access the benefits they have earned, even if they are not currently employed at the time they need them. First Shift sees a lot of pregnant workers who have lost their jobs for one reason or another, sometimes an illegal reason, who are otherwise eligible for paid leave benefits, but are prevented from accessing this safety net program that was intended for them. They do not generally qualify for unemployment benefits. Thank you for the opportunity to testify today.
Thank you. Amy?
Good afternoon, Chairperson Henderson and members of the Committee on Health. My name is Amy Sawyer, and I'm the Director of Women's and Infant Services at Sibley Memorial Hospital, a member of Johns Hopkins Medicine. I'm joined by my colleague, Raina Jordan, Sibley's Director of Government Affairs. I am testifying today to share our insights regarding maternal and infant health outcomes in the district and to highlight Sibley's Maternal Health Access Program. Sibley's Maternal Health Access Program, or MHAP, was developed to directly address disparities in maternal and neonatal morbidity in the District of Columbia. The program works with community-based providers to improve hospital services for the most fragile newborns, address adverse social drivers of health, and enhance outreach in underserved communities. Since its inception, MHAP has enrolled more than 1,100 patients, with 38% residing in wards 7 and 8, 57% identifying as Black, and 40% identifying as Hispanic. To further expand this reach, Sibley will soon announce the establishment of a collaborative relationship with a local FQHC to ensure that vulnerable patients seamlessly transition between community clinics and hospital-based services. The true value of MHAP lies in our ability to manage highly complex cases by bridging hospital clinical care with district community resources. For example, the program recently supported a single mother with 3 children facing an unexpected pregnancy and a complicated health history. Sibley's MFM team and high-risk nurse navigator integrated with her community support team, including Smart from the Start and Mama Toto Village. Together, they determined discharge barriers, coordinated physical therapy, arranged childcare, and picked up medications. And through MHAP, Sibley provided a crib, car seat, and formula while coordinating transportation and follow-up care. This coordinated ecosystem allowed for her to safely deliver a healthy baby girl and successfully transition into postpartum medical and mental health counseling appointments. While providers coordinate effectively within their own organizations, clinical teams frequently encounter patients who receive care across several different entities in the city. Sibley strongly advocates for policies that incentivize closed-loop communications to ensure vulnerable patients are not just directed to the appropriate specialist, but that their receipt of care is seamlessly communicated back to critical members of their primary care team. Our ultimate vision is a unified communication network where hospitals, FQHCs, and organizations supporting health-related social needs speak to one another in real time on behalf of the patient. In closing, Sibley shares the city's goal of improving maternal and infant health. By catching high-risk patients early and addressing critical social needs, we can help ensure that district moms and babies receive the care that they deserve. Thank you for the opportunity to testify today. We're happy to answer any questions you may have.
Thank you. Raina?
No separate testimony for me. I'm just here to help with any questions that we have.
Got it. All right. Dr. Thomas. Oh, Dr. Thomas, we can't hear you. Maybe if you take off the headphones or unplug the headphones. No.
No.
Oh, we can hear.
Yes. Okay.
Yes. Okay.
Good to
we hear
go?
you.
Oh,
Yes.
okay. All right. Sorry about that. Good afternoon, Chairperson Henderson and members of the Committee on Health. My name is Dr. Angela D. Thomas, and I serve as the Vice President for Healthcare Delivery Research at MedStar Health and MedStar's Research Institute. where I provide oversight for the MedStar Healthcare Delivery Research Network, the MedStar Women and Children's Research Network, the Center for Biostatistics, Informatics, and Data Science, and our Safe Baby, Safe Moms initiative. I'm pleased to offer updates on Safe Baby, Safe Moms, MedStar's Hallmark program, at today's Maternal and Infant Health Roundtable. MedStar Health offers a comprehensive spectrum of clinical services through over 400 care locations, including 10 hospitals, 33 urgent care clinics, ambulatory care centers, and an extensive array of primary and specialty care providers. As a not-for-profit healthcare system, MedStar Health is committed to its patient-first philosophy, emphasizing care, compassion, and clinical excellence. As part of our work, we also aim to address health disparities informed by the evidence and patient-centered care. In partnership with Mama Toto Village and Community of Hope, MedStar developed and implemented the Safe Baby, Safe Moms care delivery model, which has significantly reduced both the overall rates and the disparity rates of very low birth weight, preterm births, and severe maternal morbidity. In March 2020, the A. James and Alice B. Clark Foundation funded $27 million of the $30 million Safe Baby, Safe Moms initiative. Safe Baby, Safe Moms is a novel, multi-generational integrated care delivery model aimed at reducing maternal and infant health disparities. The initiative combined more than 70 interventions, including universal social determinants of health screening and referrals at every point of care, integrated behavioral health screening and referrals for depression and anxiety, remote patient monitoring for hypertension, diabetes education and care bundling, interprofessional care coordination, medical legal partnership services, perinatal navigation, healthy steps, didactic pediatric support, postpartum outreach and follow-up, extending through the child's first year of life. Initial results offer promise for care delivery. Important metrics such as preterm birth improved for birthing people receiving care as part of Safe Baby, Safe Moms compared to their counterparts who received care elsewhere. Additionally, results for Black birthing parents are notable. This is particularly important considering Black mothers and living in Ward 7 and 8 are 3 times more likely to die from childbirth-related complications. Women in 2 wards account for 70% of all pregnancy-related deaths in DC. Between April 2020 and March of 2025, Safe Baby, Safe Mom served over 53,000 patients and delivered over 16,000 babies. More than half of those patients were Black. These results are clear as SBSM works, and it especially works for the patients who face the greatest risk. Mothers who receive Safe Baby, Safe Moms prenatal care were significantly less likely to have low birth weight babies or preterm births. Compared to Safe Baby, Safe Mom patients, those who receive prenatal care elsewhere were 1.4 times more likely to deliver a very low birth weight baby and 1.15 times more likely to deliver preterm. I'm happy to provide more data about Safe Baby, Safe Moms in the submitted testimony, and thank you for continuing to bring attention to this important issue.
Thank you. Dr. Augusti.
Hello, can you hear me okay?
Yes.
Wonderful. So good morning, Chairperson Henderson, members of the Committee on Health. I'm Dr. Tamika Augusti. I'm chairwoman of the Women and Infant Services at MedStar Washington Hospital Center, and I'm the physician executive director for the Women's Health Service Line for MedStar Health. In my role, I provide oversight of the OB/GYN department with the highest acuity and volumes in the District of Columbia at MedStar Washington Hospital Center, and all of the OB/GYN services provided at MedStar Health. Thank you for the opportunity to present to the Council's Committee on Health an overview of our experiences in supporting expecting parents and their infants. I continue to dedicate my career to ensuring patients have healthy pregnancies and births in my clinical practice and through my advocacy work to improve the quality of maternity care in the District of Columbia. I cannot do this alone, and my partner in this work is MedStar Health. We are confronting our nation's and district's rising maternal mortality rate, which disproportionately impacts Black and Indigenous women. As members of the committee are aware, the United States still has a maternal mortality problem, with the latest being 17.9 per 100 births, and the district's pregnancy-related mortality ratio is 43.8 per 100,000 births. It's estimated that more than half of these deaths are preventable, especially concerning other stark racial inequities in maternal mortality in the district, where Black residents are approximately 81 to 90% of all maternal or pregnancy-related deaths, despite only representing half of the births in the district. Of the pregnancy-related deaths that are occurring in the U.S., an estimated 1/3 occurs 1 week to 1 year after pregnancy ends. This highlights the critical need for proper recovery and support during postpartum, a key tenet in the Women's Health Services at MedStar Health. Key findings from the district's Maternal Mortality Review Committee found that leading contributors include cardiovascular conditions, mental and behavioral health conditions, infection, and hemorrhage. We also know social determinants such as housing, access to care, structural racism, and care coordination play important roles in many of these maternal deaths. Social and structural determinants of health describe environmental conditions, both physical and social, that influence health outcomes. Addressing social determinants of health is critical to reducing inequities in health status, including maternal morbidity and mortality. Evidence shows that improving access to social services reduces the risk of developing chronic diseases and other health conditions and may also lower health costs. Recognizing this, like Dr. Thomas just mentioned, in 2020, MedStar Health, in partnership with Mama Toto Village and Community of Hope, launched DC Safe Baby Safe Moms with generous support from the A. James and Alice B. Clark Foundation to address this adverse maternal and infant health outcomes in DC. Since launching, over 53,600 individuals have received comprehensive patient-centered care through the Safe Baby Safe Mom initiative, and our data shows that racial disparities in maternal and infant health outcomes have been reduced in our patient population. At the conclusion of our 5-year project, we have been able to show that patients who've received prenatal care under Safe Baby Safe Moms had 66% lower odds of very low birth weights, 47% lower low birth weight babies, and preterm babies, 10% lower odds of severe maternal morbidity. Specifically, Black patients received prenatal care under Safe Baby Safe Moms showed similar and even slightly better outcomes with lower odds of preterm babies and severe maternal morbidity. However, an additional factor has to be taken into consideration that we've also seen the birth rates in the city change over the past few years. Births and birth rates in DC have decreased consistently over the past 6 to 10 years, with the same trends being seen at Washington Hospital Center. MedStar Washington Hospital Center remains committed to providing safe access to patients requiring obstetrical care. We expect these downward trends to continue. Birth rates have declined consistently due to a myriad of factors. As we are adjusting our operations to the changes in the environment, our commitment to our community and services that we provide is steadfast. In our commitment to the community of maternity patients we serve, our services are not changing. We recognize that the great work we've been able to accomplish with Safe Baby Safe Mom was dependent on our partnership with our community partners, and it is important that that continues, and it will. I believe as leaders in maternal care in the District of Columbia, we continue to make significant changes to improve the care that we deliver to our women in DC. As a health practitioner in DC, I applaud the Committee on Health for holding this important roundtable to address the coverage, care, and challenges of maternal and infant health in the district. Thank you, Chairperson Henderson, and the committee members for this opportunity to testify. I'm happy to address any questions that you may have.
Thank you. Thank you so much to this panel of witnesses. It's always good when we get the practitioners and institutions to sort of weigh in, especially the ones who are, I think between Sibley and MedStar, you're doing more than half of the births in the city for individuals who are choosing to give birth in a hospital. So I want to ask a couple of follow-up questions before I get there. Ms. Brown, I don't want you to feel left out. So I want to say thank you so much for the work that you guys are doing around workforce accommodations as it pertains to pregnancy. Some of the examples that you gave, just for clarification, were those in DC or really?
All of them.
All of them, including the hospital that made the patient sign a waiver or the worker sign a waiver? Interesting. We could follow up on that offline. Okay. I wanted to ask a question. One of the issues that we have had in the past in DC has been with regard to diversions in terms of labor and delivery. I think Raina knows this, and Dr. Augusti, I think I've said this before. I had that experience with my first, when I was giving birth to my first child, of multiple hospitals happened to be on diversions in DC at the same time, one beautiful day in March. And I'm curious, whether or not you all are seeing that trend going down. We got a little bit of data from DC Health about some of the diversions at the hospitals with regard to labor and delivery, but I just wanted to hear from you all.
Sure. I can speak to that to MedStar Washington Hospital Center. So over the past years, the number of times we've gone diversion has gone down. We see spikes every so often in certain months, but when you compare the past year to the year previous, the number of times diversions has gone down. I think this is multifactorial because the birth rates and the number of births happening are going down, but also we have implemented very clear plans on what to do when we're getting close to a diversion to try and offload, to try and help expedite the availability of beds. We have a very clear process, and we have our leadership is intimately involved when we're going on diversion, so it is not made by one single person, but by the group of our leaders, both in the department and at MedStar Washington Hospital Center. Putting all that together, I think, is why we've seen less number of times that we've been on diversion.
Okay. What about Sibley?
Yes, I'm happy to speak to that. I think Sibley has seen some recent spikes in that, but overall, I think we're going down on our times of diversion. Again, similarly, we have a very clear process and policy in place and really try to make sure we're not just one person is making that decision. We have a whole team with our medical director and our nursing director that are making that decision, and really looking throughout our entire women's and infant services to see what other levers we can pull before labor and delivery needs to go on diversion. Overall, our volumes have been down as well. We're experiencing that, lower birth rate as well, but still seeing some of those big fluctuations from day to day where volume may be really low one day and high another. And so our team is really looking at everything related to our schedule and making sure anything that we have, anything that we can do to impact that, that we're putting into place.
Great. One of the things, though, I wanted to ask in terms of the data, and I could also follow up with DC Health and FEMS about this, but when the hospitals report that you're on diversions, do you also report the length of time? Because I know that sometimes it could be you're on diversions for like 3 hours. It's not for the whole day. Is that information also conveyed as well?
When we go on diversion, it's for a specific amount of time, the minimal amount of time that we go for. We often say we have a conversation with DC Health saying, is it 3 hours? Is it 4 hours? And at the end of that time, we have to communicate again with DC Health, explain where we are, and then again determine if we need to be on diversion any longer and for what period of time. We never say, oh, we're going to go on diversion for the day, unless there's some catastrophic physical plant problem. That doesn't happen. So that's how we usually work in terms of how long we're on diversion. And internally, we could try the 4 hours, but we are working towards alleviating the bottleneck at the end of those 4 hours so that we can come off of diversion.
Okay. That's helpful to know. Obviously we have had a couple of situations where I don't think it is necessarily labor and delivery, but the issues have been in terms of like the emergency room where there was like a pipe that burst. Well, yeah, okay. You do need to be on diversions and probably for the remainder of the day until the repair can be made. So I definitely understand that. It is just often, though, I know that this data point is kind of used to speak to demand and capacity within our public health network to deal with the number of deliveries that we've had. And so, Dr. Auguste, I wanted to just give you an opportunity. There were a number of witnesses who testified today about some of the changes that you guys have made at Washington Hospital Center, and I wanted to give you an opportunity to respond.
Sure. Thank you very much. MedStar Washington Hospital Center had made the decision to shutter one of our 2 postpartum units because on the unit, it was not reaching capacity. We were having decreased volumes. And so we looked at the data. We looked at how many times the unit was full, how many times it was empty, how many available beds we had on the other unit, and the decision was made. to close the unit. This is, again, we have looked at the data, looked at what our services are, looked at the numbers that are coming through labor and delivery, and we really do think that this would be is going to be able to occur without significant change to any services. There is no change to any services. I've had conversations with our community partners, particularly our FQHCs, where their interaction with high-risk obstetrics, perinatal ultrasounds, none of that is changing. Our ability to take patients, nothing is changing. Our community partners being able to schedule C-sections, schedule induction of labors, none of that is changing. I understand that there is concern that that will change, but what I think many people don't have is the data that we have internally, and we've looked at that, and we know that we are going to be able to handle this. We may have, when we have a bottleneck, it's always because of what's on labor and delivery. It's not necessarily because of what's on postpartum. So that's why we think we're poised pretty well to be able to handle this change.
Okay. And it's not as though the rooms are going away. Should you see a reversal in volume, the hospital is able to adjust.
Correct. The rooms aren't being destroyed or going away. It's not. Similarly, just as we are pivoting right now, if things change in the city, let's just say a hospital closes or something and births will have to be diverted, then we always have the opportunity to reverse course. That similarly happened a few years ago when Providence Hospital was closing.
That's right. I wanted to also ask for both of the hospitals. I think Dr. Auguste, you testified at our last maternal health roundtable, and it was you, and I think you had another colleague who was with you, maybe from MedStar Georgetown, but sort of talking about some of the trends that you all were seeing of patients who were coming in. And it was from that conversation but I think also a convening that the DC Hospital Association did around substance use and pregnancy, and whether or not there were interventions or more public education that needed to be there. I was curious what type of trends you all are seeing now, being that the hospital probably has the most up-to-date data around what's happening in the maternal and infant health space in the district. You could go first, and then, of course, Amy thereafter.
Oh, sure. So when I last spoke, we had seen an unusual spike in the number of substance use disorder, opioid involved pregnancies. It was highly unusual. Thankfully, we're not seeing those sustained numbers any longer.
Right.
I think from that, and I think it's multifactorial again. I think there was a lot of education, a lot of knowledge that was shared in terms of what to do for these patients, not when they hit labor and delivery, but beforehand. And I really do think that has worked. And we're also integrated a lot more substance use disorder services for patients antenatally and when they're on labor and delivery. I think some of the trends that we are seeing now, and I'd love to hear from Amy if she's seen it, is that we are seeing hypertensive disorders like we've never seen before. Things like gestational hypertension, preeclampsia with severe features. In years past, where we on any given time on labor and delivery, where we would have 1 or 2 patients that had a diagnosis of preeclampsia with severe features, we now have 6, 7, 8 patients. The hypertensive disorders in pregnancy and before pregnancy, chronic hypertension is skyrocketing. And that is something that we are definitely noting and having to pivot and try and mitigate antenatally as well.
Yes, thank you. I would agree with that. I cannot say we're seeing a lot of patients that have substance use. I don't have the numbers off the top of my head, but it's not a significant concern. But to Dr. Auguste's point, we are also seeing lots of patients that just have that are complex in their pregnancy. They may have preeclampsia, a lot of patients with severe features, with hypertension with severe features. We have a lot of readmits for postpartum mag sulfate and patients that are really very sick, as well as diabetes, gestational diabetes, and just a lot of very complex patients, very highly acute patients, as well as patients that have significant mental health needs or even behavioral health needs. And that's where I think we're seeing a lot of this focus. So I know, we're a part of the DC PQC as well, and working on some of the same bundle. And I think it's very timely, looking at the mental health bundle this year. I think that's something that is really very helpful in this time.
Yeah. I think it's so interesting in terms of the hypertension, the preeclampsia piece. We just passed and funded legislation around remote patient monitoring, which could be incredibly helpful in some of these things, particularly Ms. Sawyer, when you're talking about the readmits, but also just sort of the monitoring and that postpartum period once someone actually leaves the hospital. Just for clarity, both of you mentioned this. You said, quote, severe features. What does that,
So,
I'm not a doctor, so what does that mean?
Sure. So preeclampsia is a diagnosis associated with pregnancy where you have elevated blood pressures and some end organ damage like kidneys and protein. We have the diagnosis comes with or without severe features, and the severe features has to do with significantly sustained elevated blood pressures or some neurological symptoms that might have like an unrelenting headache that doesn't go away or some visual changes. Preeclampsia with severe features, like the title kind of says, is much more concerning than preeclampsia without severe features. Those that have severe features need certain treatment to prevent seizures from happening. That's the magnesium sulfate that was mentioned before. So that is a progression of the disorder to almost to the highest level. So that is what we are seeing, more severe preeclampsia, worsening hypertension and disorder in preeclampsia.
Okay. Interesting in terms of this whole panel kind of being together, because I had imagined that sometimes working conditions can exacerbate or lead to preeclampsia. Is that accurate? Like if somebody is doing heavy lifting and those types of things, or?
I mean, we've seen enough of the data to show that it may cause someone's blood pressure to elevate, but the progression of preeclampsia is honestly still unknown. Someone's going to win a Nobel Prize for it because we don't know. It has something to do with the placenta and the vasculature. While, like you said, the stress and working conditions can add to elevated blood pressures, which then brings people in and gets them even, we have to do that evaluation to make sure that isn't preeclampsia. So it is contributing to the work to patients being seen, the workflow and what has to be done. But I wish we knew exactly how to prevent preeclampsia. We're getting close, but we don't have the answer yet.
It's so frustrating. It's like
it is
2026 and we have this thing that is literally causing, mothers risk and harm, and yet we have no right? Preeclampsia has been existing for decades, forever, and we still don't have an answer as to why, but also how to prevent it, right?
Research. We need to put more funding into research on women's health, particularly around preeclampsia. That's the way we're going to get the closest to it. We're getting close. There are some bright spots that we need to do. We need to push more.
Yeah. It sort of makes me think of Jaren's testimony from earlier, but just also in general, right? I remember when I had a meeting with my doula and said, like, what are your goals for your pregnancy and in your birth? And I was like, healthy and uneventful. That's it.
Yep.
Just want to survive and be uneventful. And that shouldn't, it is weird that for America, that is something that people have to say, as opposed to it being sort of just a joyous occasion, but you just want to survive it, as opposed to experience and live it. I thank you so much. I know that Dr. Gusty and Dr. Thomas and Ms. Sawyer, thank you for being. I know that you guys have crazy schedules and seeing patients and whatnot. So I really appreciate you taking the time to be a part of this conversation. If you haven't provided your written testimony for the record, please do so and update it. We're going to take a 5-minute break, and then we're going to get to our government witnesses. Thank you. Okay, we're back. With our government witnesses. We have Sarah Beckwith, who is the Senior Deputy Director for Community Health Administration at DC Health, and Melissa Bird, who is the Medicaid Director at the Department of Healthcare Finance. I need to swear you guys in. So if you could raise your right hand, well, you and anybody who might speak from your team. There we go. The friends in the back. Okay. Do you swear or affirm under penalty of law that the testimony you're about to provide to the council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth? Great. All right. I think we're starting with DC Health, and there are some slides. So Sarah, if you could just turn your mic on. And you're good. Nope. Do it again. Now you're good.
Oh, okay.
Yeah.
Good afternoon. My name is Sarah Beckwith, and I serve as the Senior Deputy Director for the Community Health Administration at the DC Department of Health. I am testifying on behalf of Dr. Ayanna Bennett, Director of DC Health. Thank you for the opportunity to bring attention to the critical public health issue of maternal health in Washington, D.C. In public health, we define maternal health as the health and well-being of women before, during, and after pregnancy and childbirth. We know that there are several factors that influence maternal health, including socio-demographic factors like race, ethnicity, education, and income, factors before pregnancy, including chronic conditions like hypertension and diabetes, pregnancy factors during pregnancy, such as prenatal care, gestational hypertension and diabetes, and factors after delivery, including postpartum care, behavioral health support, and breastfeeding support. At DC Health, we have created a perinatal and infant health framework, which aims to improve perinatal health outcomes. We focus on improving preconception health, ensuring high quality healthcare services and care, strengthening families, and promoting healthy environments. At DC Health, our current maternal health priorities are focused on reducing maternal mortality and severe maternal morbidity, improving maternal health before, during, and after pregnancy, and improving coordination across the entire healthcare ecosystem. On these next slides, I'm going to highlight some trends in maternal health outcomes. We are showing past years of data from about 2019 to 2024. It takes about a year for DC Health to validate our maternal health data. So we should have our 2025 maternal health outcomes, which I will talk about more, ready for publication by December of 2026. So on this slide, as we heard from our partners, we see trends in where district women are delivering. So we can see that the percent of births annually, we've seen increases at MedStar Washington Hospital and slight increases at Sibley. We've seen a decline in births at George Washington University Hospital. Home births represent a small percentage of births every year. And we also note that Cedar Hill was not included in this graph. They came online in 2025, but they will be included in future visualizations. We know that access to early prenatal care is critical to support healthy pregnancy outcomes. Because of DC's small population size and the relative small number of annual births that we see, what we do at the health department is we combine multiple years of data so that we can identify meaningful trends in birth outcomes. We also compare ourselves to other comparable cities that have a similar demographic makeup and population size instead of comparing us to other states and to the entire nation. So if we look at early prenatal care, we can see that DC, our rates of first trimester prenatal care initiation are lower than New York City, higher than Philadelphia, and in alignment with Baltimore. This slide shows rates of prenatal care among DC residents by race and ethnicity in the year 2024. We can see that across each racial and ethnic group, at least 2/3 of individuals are seeking prenatal care in their first trimester, which is what we're aiming to achieve. However, we see that significantly higher numbers of white and Asian women are initiating prenatal care in that first trimester. So on this slide, we can see trends in preterm births across DC residents. And here we see that rates of preterm births among Black residents far outpace other racial groups and ethnicities. And if you think back to the previous slide, the trends in prenatal care initiation mirror our trends in preterm birth. On this slide, we can see rates of infant mortality. And in DC, as well as across the country, we're seeing declines in infant mortality rates. The decrease in DC is being driven by decreases we are seeing among Black mothers. However, infant mortality rates are still 4 times higher for our Black mothers compared to white. And on this final slide with our data, we look at a ward level distribution of our infant mortality rates and our percent of births that are delivered preterm. And we can see that rates of infant mortality and percentages of preterm births are highest in wards 7 and 8. It's important to acknowledge the longstanding systemic barriers that residents in wards 7 and 8 have faced to healthcare, housing, and income, and other social determinants of health. And we know that these social determinants of health are critical in influencing the health of communities. On these final slides, I will highlight programs and initiatives that DC Health is leading to help improve maternal health outcomes and address longstanding disparities. At DC Health, our strategy framework to improving maternal health focuses on improving prenatal care, reducing rates of preterm birth, and reducing rates of severe maternal morbidity. This slide highlights our initiatives focused on increasing access to high-quality, patient-centered prenatal care. With our state maternal health innovation grant, I want to highlight the work that we have done that we heard about earlier to expand access to perinatal, postpartum, and specialty care referrals within our FQHCs, in particular in wards 7 and 8. We successfully worked with MedStar to scale up access to their Safe Babies, Safe Moms initiative, and we were able to co-locate services and referral pathways in Bread for the City and Whitman Walker Health to MedStar's Safe Babies, Safe Moms initiatives. Over the past year, we've had about 78 referrals to MedStar, and 36 of those patients have been seen. Within our Title V Maternal Child Health Block Grant, I want to highlight our work with Community of Hope, supporting transportation assistance. We consistently hear from mothers that transportation is one of the biggest barriers they face to attending prenatal and postpartum appointments. Over the past year, Community of Hope has provided more than 1,700 rides to individuals to attend their prenatal and postpartum appointments. And then finally, in our prenatal care strategy portfolio, we know how important it is to get the word out about the breadth of resources that our DC maternal health ecosystem has to offer. So we are working with the Department of Healthcare Finance to launch a maternal health awareness campaign. Our goal is to increase utilization of all of these healthcare and social care resources. The MOU is almost executed. We're working on the content for digital ads, metro ads, bus ads, and we should see the campaign being launched by October-ish 2026. For our next slide, I want to highlight our work in preterm births. So we know that it's critical that we identify women at risk of preterm birth early and get them connected to evidence-based interventions that we know work to reduce rates of preterm birth. At DC Health, we lead a preterm birth reduction initiative, and we currently work with 3 hospitals and FQHCs to deliver high-risk screening, group prenatal care, patient navigation and care coordination, and referrals to specialty care. I want to highlight the work that we've seen this year within Community of Hope, and they have reduced their preterm birth rates to 8%, which is significantly lower than what we saw in the slide where we looked at different racial and ethnic groups. With our state maternal health innovation grant, I want to highlight the work that we're doing to expand access to reproductive health care, in particular among our young adults. Although we see a smaller number of births in the 25 and under age group, we see higher rates of preterm birth. So in partnership with MedStar, we've expanded access to their kids' mobile medical unit and supported them to launch a Healthy Futures pilot, which is supporting adolescents and young adults with complex medical, social, reproductive, and mental health needs. And then with our Title V Maternal Child Health Block Grant, we heard earlier today from our colleagues at La Clinica, and we are proud to support their work to relaunch their perinatal health services. They have successfully completed their perinatal health needs assessment, and they are on track to launch services by September 2026. In terms of our work in severe maternal morbidity, we know that timely access to severe maternal morbidity data and hospital quality improvement efforts are critical to understand root causes of SMM and implement effective interventions. We've been working closely with the Department of Healthcare Finance and CRISP Shared Services, and we're on track to start receiving SMM data from the Health Information Exchange in August. So hopefully when I come back for performance oversight hearing, I should have some analyses that I can report back. And then we heard from our partners at DC Hospital Association about the work we do through our Perinatal Quality Collaborative. We know that this is an evidence-based strategy that works. And the progress that I have highlighted here, we honestly heard earlier. Next slide. So I want to end with some of our upcoming new maternal health initiatives and activities that we're working on. We're working closely with the Department of Healthcare Finance to support increased access to doula support. We're working to publish an all facilities letter, which is the best practice that we see across other states. It's a document that hospitals can post so that visitors and healthcare providers can see it, and it provides guidance and sets expectations on creating a doula friendly environment in a hospital and ensuring that doulas are part of their team-based care models. Our preterm birth reduction request for application is on the streets. We encourage all of you to apply. This cycle, we have learned from our past successes across our partners. So we're requiring, in addition to the high risk screening, group prenatal care, and referrals to specialty care, we are requiring all of our funded partners to support transportation assistance and perinatal navigation and care coordination. In the data and surveillance work that we are doing as a health department, we are working hard. We hear everyone. We need more timely access to maternal health data. We launched a dashboard this year, visualizing our preterm birth data, and we are about to launch by December of this year an additional dashboard so that we can visualize more maternal health indicators. We're also working to publish more frequent and smaller publications on maternal health outcomes. So my team is working on 2 data briefs to highlight trends and policy recommendations in severe maternal morbidity and preterm birth. And finally, we are working to improve the data that healthcare facilities are reporting to us and that we're able to share back to the public as part of the Better Access for Babies to Integrated Equitable Services Amendment Act. We are very close to finalizing the regulations that aim to standardize hospital discharge services and education before, during, and after delivery. These regulations will require hospitals and birthing facilities to report to DC Health information about newborn screening, lactation support, education, discharge standards, and clinical quality measures. As part of this legislation, we are working on a hospital report card that will summarize these measures across our hospital facilities. And so again, hopefully when I come back for performance oversight, I'll have a more solid timeline that I can share. Thank you for the opportunity to testify.
Thank you. We're gonna switch over, and Melissa has slides too. Give us just a moment. One minute. Okay.
Okay, thank you. Good afternoon, Chairman Henderson and members and staff of the committee. I'm Melissa Bird, and I serve as the Medicaid Director and Senior Deputy Director of the Department of Healthcare Finance. I'm going to go to the next slide. As was alluded to earlier, DC Medicaid is a key source of coverage for maternal health services in the district. In calendar year 2025, we paid for a Medicaid program paid for more than 40% of all births in the District of Columbia. The services we provide are comprehensive, including but not limited to doctor's visits, hospitalization, lab services, dental, behavioral health, reproductive health, and all the pregnancy, labor, and delivery, doula services, as you've heard earlier today, and midwifery. And we also make available breast pumps to mothers as well. I will highlight, we've heard throughout the morning about the decline in the birth rate. When you look back at what we presented at the roundtable in December of 2023, we showed about 3,800 births that we covered in calendar year 2022. So you see a slight decline of a few hundred there. Next slide, please. I thought it was important to highlight pregnancy coverage and how it's been maintained over the past year, since we've also been through a number of significant changes to Medicaid eligibility and Alliance eligibility in the District of Columbia. So we still lead in terms of the eligibility levels. We cover Medicaid pregnancy up to 324% of the income level. But I do think an area of focus and attention over the next several months too is the potential challenges ensuring continuity of care and coverage. One, because of the changes to eligibility over the past year, and then future as we implement the One Big Beautiful Bill Act requirements like work requirements or more frequent eligibility checks, seeing how that works. And so what you see before you still is the targeted reductions in Medicaid eligibility were focused on those first two lines of Medicaid childless adults and parent caretaker relatives. And then if you drop down to the third line, you see where our coverage for pregnant women remained steady at 324%. I also wanted to highlight the FCEP program, if you will. It's from conception to end of pregnancy. And this is the opportunity where we can cover individuals who may not otherwise be eligible for Medicaid. Members in our Alliance program, when they become pregnant, they move into this FCEP coverage as soon as we know that they are pregnant. And then also the individuals who lost Medicaid eligibility, most folks had the opportunity to move into the Healthy DC plan, which is a basic health plan option, which does not cover maternity. It is specified in basic health plan regulation that women have to go back to the Medicaid program, if you will, for maternity coverage. So we had that. We had some discussion earlier from, I think, Mary Center about some of the issues kind of coming into play because of those now like transitions in coverage. We can say as of June 29th, we had 99 residents successfully transferred from the Health Benefits Exchange or the Healthy DC program and moved into their active Medicaid. And we have 5 individuals who are still in the process of making that transition. The issues to date related to those changes is that sometimes, from a systems perspective, we have to fix something in our system. It's a specific case issue. Some of our cases are not automatically transferring from DC HealthLink over to the DCAS system, which means then we do it manually, which again just takes more time. And then I think we talked about last time I was here, we are sometimes hearing of requests made to residents to show proof of their pregnancy, which is not required for Medicaid. It is required, I believe, for cash assistance in their third trimester. So I think there's where some confusion lies. So we continue to monitor those issues as we go forward with the changes in Medicaid eligibility. We can go to the next slide, please. Also, when I was here for the last roundtable, we highlighted our outcomes mostly through our managed care program, where most folks who, if they're pregnant, are receiving their care. We still do not meet most national standards for prenatal and postpartum care. If you compare and contrast again from the 2023 data, which focused on measurement years 19 through 2022, I believe, there's not a whole lot of difference. It's kind of remained relatively steady in terms of what you see before you. What we have done since then is, as you all know, we have an annual technical report that we have to issue on our managed care program. Our Quality Improvement Organization, or QIO, does that study for us. And in our most recent report, we included a maternal health and birth outcomes focus study to answer the 3 questions that are before you. To what extent are Medicaid managed care enrollees who have given birth receiving early and adequate prenatal care? Do birth outcomes appear to correlate with the level of prenatal care received? And do disparities exist in the adequacy of prenatal care and birth outcomes based on race, ethnicity, and or residence by ward? If we go to the next slide, you'll see some of the findings. And less than half of enrollees received early and adequate prenatal care, which I think is consistent with the overall district data we just saw from my colleague. Ms. Beckwith. I thought this was interesting. We only saw a correlation between early and adequate prenatal care and preterm births for Ward 1 enrollees only. So something for us to investigate more. And then we saw regarding birth outcomes in Ward 7 and 8, preterm birth and low birth rates were actually slightly higher than our DC aggregate rates. But still, those aggregate rates aren't really anything to, we still have overall improvement to do. And then also the QIO determined that the variances in prenatal care, preterm birth, and low birth rate by ward are not statistically significant. So since then, we've continued to work with our managed care plans. We've started requesting enhanced monthly data reporting, trying our best to improve early detection, and then really figure out how can we change our outreach methods in order to reach the folks that would ideally be in care sooner than later. Next slide, I wanted to touch on the recommendations that we presented from the Perinatal Mental Health Care Task Force back in 2023. There are several recommendations that we have implemented since then. And I would say this also just speaks to a number of the rolling initiatives on focus on maternal health, starting with the Maternal Health Advisory Group and designing and implementing both extended postpartum care up to 12 months and doula services. That work really moved into the Perinatal Mental Health Task Force. And you can see before you, we've added new Medicaid provider types. We've been working on the collaborative care model, doing better integration of behavioral health case management in our managed care plans. And then that rolls into our TEMA provider or TEMA efforts, which I'll go into on the next slide. I would say those efforts have really evolved into a more integrated approach because of the Transforming Maternal Health Initiative. Last year, we were one of 15 states awarded $17 million over the next 10 years to really look at how we can implement a payment and care delivery initiative to support whole person maternity care. You can see the TEMA aims before you, and it's a fairly long period of time of 10 years divided into both into two phases, one of which is pre-implementation, which is where we are. So the TEMA work overlaps and builds on past work. We can go to the next slide. And I also wanted to highlight, while we have not implemented all recommendations from the Perinatal Mental Health Task Force, what we line up here is where some of those recommendations fit into the work under the TEMA initiative that's ongoing. If you go to the next slide, since we were awarded the TEMA initiative funds last year, we've reconvened the Maternal Health Advisory Group. It was meeting on a monthly basis until this summer. We're moving to a bi-monthly cadence. We've aligned with key partners. I thought that was a really great thing we've heard throughout the morning is I don't recall ever hearing collaboration as much as I have in past roundtables or hearings about maternal health. Probably going back 5 years. We've been excited to support providers through the Provider Incentive Program. We were able to pay out a little over $200,000 to 17 organizations, key maternal health providers like FQHCs, doulas, and other physicians. And then this next year, entities will be eligible for up to a little over $60,000. We've engaged focus groups in collaboration with the Community of Hope to collect lived experience insights. We've completed journey mapping to inform screening, referral, and follow-up processes specific to behavioral health and social needs. This was done in collaboration with the DC Lab. We've used our integrated care DCTA program technical assistance to prepare providers for value-based payment specific on maternal health. And then this is exciting for me, and I think it speaks to some of the work we've been able to accomplish is that we've been able to add 3 staff with a 4th to come on board, focused specifically on maternal health, thanks to the TEMA grant funds. Next couple slides, I'll focus on doula services. Access is improving, but the progress is really slow and incremental. We had 24 beneficiaries utilize doula services in 25. So that's great because it's up from 6, but none of those numbers are amazing. We have 43 doulas enrolled in the program as of April. So excited to get out of the teens. which we had last year. I think we were around 16, but we only have about 4 of those doulas billing. So 43 is great, but I think you heard earlier, and I think you heard earlier about some of the challenges. And I think we see that reflected in just the 4 doulas billing at this point. We've partnered with the Doula Learning and Action Collaborative to establish the State Doula Council, and we've continued to engage the managed care plans on trainings for credentialing and billing. Next slide, please. We've integrated or opened up the integrated care DC to doulas, so they're receiving technical assistance on a number of areas, also with how to connect and provide information into the health information exchange. We have and will likely issue in August detailed billing and credentialing information targeted to doulas. So I can't recall if there's, I know Crystal referenced a checklist. I know like in one of the documents, it is a literal, claim form, and it goes line by line. You don't need to report anything here, or this is what you say here. That level of detail that I am hopeful will be helpful, particularly for a group of providers that's traditionally outside of the health insurance kind of payment model. So you'll see that on our website next month. And then we've heard, or in some of the written testimony, concerns about rates. We continue to collect information. We are looking at the rate, or started discussing, but related to TIMA, will certainly be considering the doula rates going forward. I do want to note there was an inflationary increase for this fiscal year of 2.6%, so we're keeping up a little bit, but I know for those in the profession may not be sufficient. And then as we look forward, so on the next slide, over this year in 2027, Ms. Beckwith already mentioned the public awareness campaign, so working with DC Health on that. We're continuing with our technical assistance, so launching 2 types of support related to digital health and whole person care. The provider incentive program, as we go into 2027, will have up to $4.3 million to support quality improvement. And again, the transition, getting us to value-based care and payment. And then finally, how I started out, just looking at access and monitoring any changes causing issues with eligibility because of just general changes to the Medicaid program. So that's all I have to present, and look forward to taking any questions you may have. Thank you.
Thank you. Thank you to both of you. Melissa, I was hoping you would put on your list implementation of remote patient monitoring.
I'm surprised it took you so long. But I'm glad we're just starting out with it. It is part of the TIMA model.
Yeah.
As we've discussed before. So I know as we move forward on the payment methodology, remote patient monitoring will be a discussion point in that development.
Great. Well, thank you guys so much for the testimony. I think you covered a variety of different things, and also all the various pieces, right? From prenatal to what's happening in sort of in the postpartum space. I have some questions just to get some clarity on some things, and also follow up on some other stuff that we, talk about on a variety of different issues. For the public who may be watching, we go through budget and performance oversight hearings with all of our agencies, and in all of those settings, we often talk about maternal health. So this is not the first time that we're having these conversations, but it is an opportunity for us to just focus in particularly on one issue. I wanted to ask a clarifying question first to Melissa with regard to the From Conception to End of Pregnancy program. How long does that run for in terms of length of time? So for instance, right, we cover 12 months of postpartum, or 3 months here or that, but like for this particular set of folks, how long does it go?
Sure. It's the old school coverage in terms of it takes you through pregnancy plus 60 days. Unfortunately, we were not able, and we're not allowed to extend to the 12-month postpartum period
For that particular
group. Yep.
Okay. So what happens though if someone has a complication postpartum?
If they're within their 60 days, it's full Medicaid coverage. If it's beyond the 60 days, if they are an alliance member, they would transition back to their alliance coverage.
Okay. But with all of this, and this kind of comes up even in the data that Sarah, you shared around prenatal visits, none of this kicks in unless somebody raises their hand and tells us they're pregnant.
It's not the only way. That
Okay.
is possibly maybe the fastest way. If we see a claim for prenatal care, that's one way we can identify it. We are working through ways through our health information exchange where we could potentially have the ability for a provider to flag it, an HIE that would come to us that would offer us
That's a
ability.
retro though, right? I mean, applicability. If you're seeing a claim that comes through,
Yes, it could be in that sense. It just depends on how timely they claim. So the self-reporting is again going to be the most expedient, but it's not the only way, but the most likely way.
okay. It seems to me a little bit that the numbers of individuals who are seeking prenatal care beginning in the first trimester or even the first 2 trimesters hasn't really changed much. What needs to change in terms of our outreach piece around some of these important things, right? I mean, we heard from, 2 of our hospitals talking about the increases that they're seeing around hypertension, gestational diabetes, preeclampsia, all of these things. Like, if we could catch it early, it could be managed, as opposed to catching it in the 3rd trimester, which at that point now you're having to take some more extreme measures to ensure the safety of the patient and the child.
I think, I mean, and then I'll add an additional concern before responding a little bit. I do think too, as we move forward with more eligibility changes in the Medicaid program, while our pregnancy coverage remains stable and static in terms of what's available, we heard Ms. Beckwith speak earlier of that, you're talking about preconception care too. And so I do think it's an area we're going to have to look at going forward if someone is like a childless adult and having to maintain a work requirement and what's happening to their coverage and their access, right? To actually try to respond to your question, not add more concern. I think that the outreach is always a question. I am cautiously optimistic with the public awareness campaign. Part of the scope of that is really to make sure folks understand, what Medicaid eligibility is. And then what we've always heard is, making sure folks understand what services are actually available to them if they're within the Medicaid program. And then also just teaching folks or making more awareness about what, that prenatal or maternity care is. And so that's one way of a more kind of holistic approach and trying to kind of really have it out there for folks to understand. And so that when they do get their call or a call for their managed care plan, they know, oh, wait, I understand why they're doing this now. Let me connect with them. Or even better, I am pregnant now. So like, I'm going to reach out to my physician or my care provider and initiate that myself.
Yeah.
I don't know if you have anything to add.
Ms. Beckwith, I wanted to ask questions about the preterm birth reduction initiative. So DC Health continues to administer this grant program, even though grantees have shown rather uneven outcomes, I would say, in previous years. Why does the agency still believe that this grant is a productive use of public funding?
We do think that it is a good, effective use of funds. We have looked at what are the interventions that work. And that's why with this current RFA, we're requiring all of our partners to include transportation assistance, perinatal navigation. And so I think that we've had a couple cycles to understand where our partners struggle and need additional support. And so with this upcoming RFA, I am hopeful that we've been able to learn from our successes and our challenges.
Okay. DC Health's preterm birth dashboard indicates that the preterm births are rising in the district, which I think you guys said a little bit in your testimony. So we're at 12% of preterm births in 24 compared to 10% in 23. The rates are much higher for Black birthing folks in the district, that 15.2%, which is well above the national average, which is like 10.4. Beyond just the initiative grants, what are some other initiatives that we're investing in or ways we're trying to bring that number down?
We're also working through our maternal health advisory committees to help, although we don't need to fund a partner in order to convene them and help to coordinate and organize our work. So through our state maternal health innovation grant, Dr. Gray, who is behind me, is working to lead our maternal health task force. And so that's where we brought in some members from all of our task forces so we can start to streamline. And we're focused on, we have working groups focused on community engagement, data, and innovative models of care. And so through this task force, we have developed a maternal health strategic plan that is about to be published on our website. And we had held a maternal health symposium back in 2024, I believe, and we're going to reconvene. So by the fall, we're going to bring back all of our partners. They made action commitments in those categories. And so that is a way that we know we need to do something different. And we're really trying to coordinate work that, as we've heard, there's a lot of collaboration happening, and we want to have us aligned in terms of our strategies and outcomes.
Yeah. Okay. So the Office of the Chief Medical Examiner's last maternal mortality report was published in 2024, but it was based on 2022 data. Does DC Health or does Healthcare Finance have access to more recent unreported data?
I don't think we do.
Okay.
I mean, I think we would have typical claims data, that kind of reporting that would be more recent than 2024.
Okay. I would just, it would be nice to know what the rate is. Even, I mean, it's 2026 and we're still operating off of 2022 data. I know that the Maternal Mortality Review Committee, it is a more in-depth process, right? They're looking at case notes and all of these different things, but even just pure numbers of like what's happening. All of that comes from OCME?
We can get back to you on that.
Okay.
I don't want to misspeak.
Okay. All right. One of the recommendations from the last maternal mortality report was expanding the number of social workers in hospitals to help new parents. And I think one of the FQHCs, I think it was Mary Center, who talked about they have actually taken that up and they have increased the number of social workers that they have working in terms of their women and infant health program. How is this recommendation being implemented, or is it something that's been raised with the PQC members?
I can speak for the work that we've done at the agency to improve social worker licensure that we have talked about. I would also add that through Healthy Steps, we actually work to support hiring of Healthy Steps specialists, which are typically social workers. So DC Health has worked to increase access and capacity of our social workers across hospitals and FQHCs. In terms of working with the PQC, in order to increase capacity of social workers, I'll call Dr. Gray up.
Okay. Dr. Gray, if you could just introduce yourself for the record.
Yes, good afternoon. Dr. Tiffany Gray, Maternal Health Program Manager at DC Health. So that is an initiative that isn't currently being implemented through the PQC, but as Sarah has mentioned, through many of our initiatives, including through our state maternal health initiative and grant, and even with our preterm birth grant, the emphasis has been on ensuring increase in staff, such as perinatal care coordinators who can help to also facilitate some of the care navigation and referral to additional services that impact patients as well. So there is work across the board for many of our grants of building social work teams, legal teams, including with our partnership with MedStar, that are able to help support residents and patients.
Okay. While you're there, Dr. Gray, I do have a couple other questions about PQC, if that's okay. One of the focus areas for the PQC has been around severe hypertension in pregnancy through, what do they call it? The Alliance for Innovation Severe Hypertension Patient Safety Bundle. A lot. Okay. So in the FY25 performance oversight responses, DC Health reported that they have transitioned to the sustaining phase for this project. Do you all feel confident that the hypertension rates are decreasing sufficiently to move to this stage?
Yes, the DC Hospital Association, which implements and leads our DC PQC efforts. And so, as you mentioned, the Alliance for Innovation on Maternal Health AIM patient safety bundles. They're implementing the severe hypertension bundle, which they've transitioned into the sustainability phase, as you mentioned. The PQC still provides ongoing technical assistance for the clinical hospital teams. That includes for data submission as well. And it coincides with the obstetric hemorrhage patient safety bundle that's also being implemented. So there's patient and provider education that's still being implemented and provided through the efforts through the PQC.
Okay. Just for the public to know, so the data that shows hypertension pregnancy in the district decreased from 9,000 individuals in 2019, which we were all going through a lot in 2019, but 9,000 individuals in 2019 to 7,884 individuals in 2023. So there has definitely been a decline, but when we shift to the sustaining phase, it's not in the same high priority levels as some of the others. So that's why I wanted to ask that. The PQC has also focused on obstetric hemorrhage, including starting a community of learning in 2025 to improve patient debrief and recovery practices. What improvements have we seen in terms of this particular area?
So similar to some of the outcomes we've seen with the hypertension bundle, one of the key examples I'd point to is the time to treatment. So that's a core indicator or source of data across the board for the patient safety bundle. So it looks at time to treatment in the event that, a patient is presenting symptoms or signs of an obstetric hemorrhage, or in the event of a hemorrhage that the hospitals and provider teams are responding effectively. It also includes developing clear policies and workflows and procedures for what to do in the event of a hemorrhage event. Another core component of that work is provider debrief. So the clinical teams meeting after events to talk about essentially what went well, what went wrong, and how they can make changes or shifts in the future.
Okay, thank you. I want to switch to talking a little bit about diversions. So, Ms. Beckwith, we heard testimony from public witnesses who were concerned about some of the changes that were are being made at Washington Hospital Center. And some of the concerns is around what will this contribute in terms of decreasing the amount of capacity that we have available. Obviously, or I'm not going to say obviously, but I would think in terms of protocol, Washington Hospital Center would have had to report to SHPTA, which is the State Health Development
Planning and Development Agency.
Yeah.
I just asked Mateo.
Because
I knew you were going to ask.
Yeah. So they would have had to report this to SHPTA and provided some type of information and data, not just saying like, hey, we're going to close down this unit. Good luck to you.
We're currently in conversation with MedStar.
Okay. About this.
On this issue. Yes.
All right. In terms of diversions across the board, so you all provided some information about diversions from the birthing hospitals. If a hospital has a high number of diversions in a short period of time, What does the corrective action look like from DC Health on that?
I will need to have my colleagues in the health systems preparedness administration reach out to you, Sam Hurley. He can really give a much more comprehensive response.
Okay. So the fun part of you being here to represent everybody within the agency. One of the things that we obviously heard some testimony from our FQHCs around their particular role in all of this, because they see so many of the patients. We had heard from the CEO at Mary's Center, who flagged that there's currently no standardized data sharing or transfer agreements that ensure a patient's prenatal record follows into a hospital for delivery and then back into postpartum care at an FQHC. How can we address this transition challenge that we're having? So let's say, for instance, because we know that there are quite a number of individuals who are not seeking prenatal care at all. For some folks, they're just arriving to the hospital when they're in labor, but there is no standard practice in terms of connecting the patient back to a primary care home for a follow-up. I feel like we do a stronger job of this in terms of trying to connect the baby to a primary care home, as opposed to, the birthing person, to make sure that they have someone who's checking up on them in a postpartum space. Is there something we could do better to address this particular challenge? And I don't know if this is a question in terms of care coordination with the MCOs or something else.
I think, I don't know the specifics of the data sharing between FQHCs and hospitals, but we do have CRISP DC, where all the FQHCs and all the hospitals are participating. And so if there is available health information, it should be accessible. So I'm happy to follow up in terms of maybe talking with the hospital and primary care associations to seeing what is lacking there.
Okay.
And I'm not a clinician, so I don't understand all the things that need to be shared back and forth. I would also say, to your point, in terms of like trying to connect an individual back to a primary care home or a maternal provider home afterwards, I do see that's where the managed care plans would certainly play a role. I expect they would see also utilizing CRISP DC, the admit, discharge, transfer notices, and be able to follow up timely, as we would expect them to do.
Okay. Can either of you provide an update on the implementation of the comprehensive newborn screening and testing new hospital discharge rules?
Yes, that's the baby's bill. So those regs are with our senior leadership for review right now.
Okay.
And then they will be sent through the usual rulemaking process to EOM. And
so we'll see them in 2027. I'm sorry, Sarah, that's unfair for you. That is unfair. But can DC Health alert us once it leaves
Absolutely.
your building? Because then we can know who else
Yes.
to sort of bug about it.
Yes.
Okay, great. All right. So one of the testimonies that we heard earlier today was around this critical piece around nutrition. And WIC is great. And also, I feel like WIC is limiting in terms of truly being able to meet the need, especially since not every grocery store or market in the district, even except WIC, can participate in that program. Are there other things that we could be doing to enhance the nutritional outcomes for pregnant individuals?
I can speak to a few strategies. You'll be pleased to know that through our Instacart pilot, we're working with the Deputy Mayor for Planning and Economic Development's Healthy Families, Healthy Futures program. The cash assistance. So all of those individuals are receiving a free membership to Instacart. So let me go back. We across DC Health continually look for opportunities within our MCH initiatives, chronic disease management. This could be because I've got a background as a dietitian. How can we integrate nutrition support? So also with all of our home visiting work, Help Me Grow, as well as across healthcare providers and health centers, my team has developed we have a federal nutrition program toolkit training where we can train individuals, and it's not some heavy certification that you need to go to, but to understand what are the federal and local nutrition programs we offer in DC and how can you refer individuals to them. So we are working to help increase nutrition access during that prenatal period. I also know that Food and Friends, they do work with pregnant women, and Director Byrd might be able to speak more to this. We were hopeful about the 1115 waiver application. It did have a nutrition support component. I think it's on hold right now.
So I'm happy to speak to that. The waiver approval process is moving forward. We don't expect it to be approved as we submitted it. What we are doing, and we've discussed, I think within the last month with this MCAC, the MAC subcommittee that focuses on this, that we're working on a concept paper specific to food and nutrition with a maternal health component to it to try to re-engage our federal partners and potential steps going forward and how we could bring in more food as medicine. I will say from Department of Healthcare Finance, we have the Produce RX grant too that support folks with, I believe it's diabetes and hypertension and getting access to food. And then I referenced earlier some of the like journey mapping that was done with the DC lab. And part of that was also those screening and referral processes, not just health specific, but those social determinants of health, including access to groceries, to food, et cetera. So there's some components that are coming into play and just in terms of our ability to identify the issue and then refer or connect someone to supports as needed.
Let me follow up on that. So the lab at DC shared an update at the May Maternal Health Advisory Group on their research to determine how we can improve perinatal screening and referral process for Medicaid patients, noting that the majority of screening and referrals stop after 3 months of postpartum. DC Medicaid covers women up to 12 months postpartum. What guidance has healthcare finance given MCOs and providers to ensure that mental and behavioral health needs and other needs are still being met in that 3 to 12 month period?
I don't know that we have provided direct guidance. Certainly something we'd be willing to do, particularly with the results of the lab work that were shared last month. I'm just trying to think through. I don't recall if we've done something more pointed than that. So I will follow up. And if we haven't, I'm happy for us to start work on that.
Okay. In that, I also want to follow up on the perinatal mental health task force that is housed out of healthcare finance. During the roundtable that we did on this in 23, one of the co-chairs for that task force stated that she believed a priority coming out of the task force report was really a need to expand the continuum of care services for perinatal mood disorders, including perinatal intensive outpatient programs, mother and baby inpatient units, so they don't separate the babies. What efforts have we been making around this perinatal mood disorder piece and the services that we can provide in the most compassionate way possible?
I'll touch on a couple things. First, I mentioned earlier about how case management before behavioral health services is now provided through a managed care plan along with other services. So that's one component, and just in terms of trying to manage the whole person and being aware of what's happening in both mental and physical health. The second is probably an area that also addresses this is the collaborative care model. I think Sarah may have spoken to it a little bit earlier, but that's where we have a primary care physician, a behavioral health care manager, and psychiatric consultant delivering care management in a primary care setting too. So that can help someone if they're in a postpartum phase.
Okay. Well, let me follow up on some of the more specific recommendations from the task force, and we could kind of see where some of these things are. So one of the recommendations was for quote unquote fast tracking to get pregnant patients insured within 28 days of application. How are we doing on that?
We have not done that, I'm pretty certain. I'm going to say we have not, but I will say, I mean, one thing, and we'll follow up on this, is to see. So I know when we were talking about, think of this real quick. I think it's the postpartum care. I'm confusing things, but before our more recent Medicaid eligibility changes, most women were already enrolled in Medicaid at pregnancy. I think it was like 5% that maybe were not prior to the pregnancy. So I think the first question for us to follow up on is, when are we seeing someone come into coverage related to when they may be pregnant? And I think this is probably a more recent issue because of the eligibility changes, right?
Right.
And see where we can support on that. And I think that ties into the comments earlier on the presumptive eligibility as well. You know, I don't know if it was, you know, we always want folks to get into coverage if they're eligible for it as soon as possible. Certainly if you're having a health condition or you're pregnant and in a situation where specific or specialty care is needed, is because of how the level of coverage we had before, most people were likely covered. And so as those things are changed, we need to probably think about how we adapt to that to ensure that we still have the fastest pathway to coverage available to individuals. So we'll look into the data on that and see what we can, if we can make conclusions, and then where we see.
Okay. I mean, I think one of the things too that's sort of similar on this issue. So in the performance oversight responses that Healthcare Finance submitted for FY25, you all noted that there were 117 Medicaid enrollees who would be potentially shifted to a healthy DC plan when their 12-month of postpartum coverage expired. So yeah, I guess the question in that is, how many of them actually moved? And when someone who has shifted from Medicaid now is has a confirmed pregnancy, how long is it taking for Healthcare Finance to switch them over?
At the timeline, but I can walk through the process.
Yeah.
Eugene Sims, I'm the policy director at Department of Healthcare Finance, DC Medicaid. So for the timeline, it varies per case because, you know, there are different things that happens with each reported pregnancy. But the system we've set up with our colleagues at DC HBX is that either an MCO or the resident is going to report a pregnancy to DC Health Link. DC Health Link has a team of case managers who are then going to reach out to the resident to confirm the pregnancy and complete the paperwork that's necessary to redetermine eligibility. So what that looks like is them entering a change of circumstance in their system. And there's two pathways for that to come back over to Medicaid. Either it's going to automatically go over to Medicaid through something called our kind of automatic case transfer process, or if that case transfer fails because of a failed match with our system DCAS to DC Health Link, the caseworker is going to manually enter that information into DCAS so that our caseworkers at ESA can determine Medicaid eligibility. That we work ESA, DHCF, and HBX work very closely to make sure that eligibility determination happens fairly quickly. It can be, if we have that automatic transfer, it can be as simple as like an overnight case transfer.
Right.
Caseworker touches the next day, Medicaid eligibility is established. And then there's a process of selecting your MCO. If you are, let's say, a AmeriHealth on the basic health plan side, healthy DC plan, you most likely want to be back in AmeriHealth on the Medicaid side. You reach out to us, let us know that. You reach out to the enrollment broker, let them know that, and you're placing your plan in just like that, you're receiving you have the same MCO, receiving mostly the same scope of services that you were in Healthy DC plan, but now you have these more services because now you're enrolled in Medicaid. That whole process can be fairly quick because it's simply, reaching out, reporting a change, and then having that change to get sent to district direct DCAS. It can be as under a week. It could be also if there's something like we need a verification of income, or a few instances we've seen is that that birthing parent, that pregnant individual will come back to Medicaid while the rest of that person's household was doing something like a renewal. So those are cases where we might need to do a few more actions to make sure that Medicaid eligibility is established. But we have a work group with HBX where we were monitoring all these cases. That's why we know the exact number of people that have come back over. And whenever something's going wrong, that's escalated to myself and my team, and we work to resolve it.
Okay. Okay. I think, Melissa, as you sort of said, this is going to become an issue more probably in the next year and a half as things are shifting and changing on that side. And that's definitely something we want to keep an eye on. Another recommendation was around developing a district perinatal psychiatric access program. Yeah, I think this is it might be more of a Department of Behavioral Health question, but I don't know if you all have had a conversation with DBH around, is there a way for us to collate who are the providers in the district who do perinatal behavioral health?
Psychiatric work.
Yeah. So the whole point, I think, was so that there's not guesswork, right? If somebody, we had a public witness who testified today. She was like, I know what the issue is. And it feels, you need the help and support to do it. My fear is that DBH would just say, oh, we'll just call Access Helpline. And Access Helpline is just going to give you a PDF of all providers that isn't specific to this type of work.
Through the PQC, have we done any of that work?
So some of that work is being implemented or worked around through the work, as was mentioned earlier about the perinatal mental health working group.
Okay.
And so it's bringing together many of the key providers who provide those specific services around perinatal psychiatry care. And so the hospital teams, the care teams are beginning to have discussions about when we screen and identify a patient who is in need of additional services, making sure that we have a clear process or clear guidance of where to direct them to so that there are services available. So there is ongoing conversation and collaboration with our partners at the PQC and some of our birthing hospitals and FQHC's partners at Department of Healthcare Finance to make sure that we're building out the necessary services for patients.
Okay. I think one of the requests I would have is, as you guys are having this conversation with the PQC, it really is like, what is a resource guide for the public of who do you call? And even just share that with the Access Helpline, because I think that there probably would even be family members who are like, okay, let me call DBH. And that is not going to be helpful for this, I think, unique type of situation. To just refer someone to a traditional behavioral health provider is not probably going to accomplish what is necessary here. But it's good to know that these conversations are ongoing. So we could follow up with the hospital association to try to get more details around the timeline for developing something like that.
I can also add that we know that this is a need. So we are at DC Health applying through HRSA to a funding opportunity that is sort of like DC MAP, which is a pediatric psychiatric teleconsultation. This is for the perinatal space.
Okay.
And it would allow us to screen and then give providers a tool to have psychiatric teleconsultation for prenatal and postpartum women with mental health and substance use concerns. So hopefully we'll have good news that we've been selected.
And if I could add as well, through our work, through our state maternal health innovation grant, in our collaboration and partnership with MedStar, we have clinical providers who are providing training for providers in the district, including with our two co-located sites at Whitman Walker and Bedford the City. So we are also working to ensure that providers are trained on how to appropriately treat and refer and screen patients as well.
Great, great. Melissa, you talked a little bit about the healthcare finance moving into the what is it called? It's not incentive model, but value-based care. There we go. Yeah, value-based care. And I'm curious how that will play out in the maternal health space, and whether or not there will be any metrics around what we're hoping for MCOs to sort of meet in this.
Go ahead and ask my colleague Joe Weisfeld to come up because he can speak this off the top of his head and I cannot. But a couple different things. We earlier this year, February, March-ish, maybe, I think had our quality, our staff folks who are in our quality division present to the Maternal Health Advisory Group on the value-based care roadmap for our managed care program, of which maternity is a component of it. I'm going to say this and then Joe's going to clean it up, but the group has gone together to look at all the different kinds of metrics and measures that we would look at for maternal health, and then how can we pull it together and make them as unified as possible. So I know some of the prenatal care is included in the measures and so forth, but with that, I'll move it over to Joe.
Yes, Joe Weisfeld, Director of the Healthcare Reform and Innovation Administration at DHCF.
You have to speak up, Joe.
Right.
Excuse me.
Better?
Yes.
All right. So yes, last year we released a 5-year framework on value-based payment. The point here is to drive even more adoption of value-based payment in the district. We had seen pretty slow and not most aggressive use of VBP within our plans. And so this was a framework to say over the next 5 years, this is what we want to see. And part of that work, we said, we can only go so far in terms of what we direct the plans to do. So we went as far as we could without making it a state-directed payment, which requires a whole other set of things. So this is as aggressive as we could be without it. And so we set targets that the plans have to meet related to how much money they spend on arrangements in value-based payment. And those percentages grow over the years and get more aggressive in how the types of arrangements what they have to be. Within those targets, we said one of those markers has to be your value-based payment arrangements have to be tied to primary care, pediatric, and/or maternal health.
Okay.
And within those, to count for compliance with the contract, you have to use at least one of our preferred measures. In maternal health, we said there are 3, we'll call them subdomains in maternal health. And this applies to primary care, pediatric, and maternal health. But in maternal health, those 3 domains are prenatal, labor and delivery, and postpartum. And there are 5 to 7 measures in each of those buckets. For a plan to meet the maternal health marker, for instance, they have to have at least one of those preferred measures in each of those subdomains. They can use more, but we're trying to standardize and get more aligned across the board on those measures and driving more and more adoption within those 3 areas, including maternal health.
So when would be the appropriate time to ask for how it's going?
So this is the first year of that.
Yeah,
So
that's what I'm asking. When is the appropriate time?
So we've set up a timeline that allows us on an annual basis to look exactly at that.
Okay.
And so these arrangements are in the calendar year. We're going to give ourselves 3 months for claims to run out. And then we have a process to look at those in the spring every year and make a decision if we need to change anything, measures, targets, ask for CMS approval for anything, funding and budget development, et cetera. And so we're going to do that on an annual basis. But that first cycle really takes 2 years before we can change anything. And so we're saying for many years now, we've said, let us have some time. And so for those who've been kind of 1 year approaches. This is a 5 year approach where we said, these are our timelines. This is when we're going to look at it. This is when we'll get more aggressive if we need to. This is how we can align it up with all of the other policy decision-making processes. So I think that 5 year process hopefully holds us a little bit more accountable to keeping the momentum here.
Okay. It's a great word for it in terms of the momentum piece, because what I don't want is like it to kind of lose its luster in terms of our focus on things. A couple other remaining questions and then we can go. Has healthcare finance or even DC Health had any conversations in the last 6 months or so with Planned Parenthood about how things have been going after they've been sort of cut off from federal support, but they had a lot of patients who were receiving maternal care with them?
I can start. We actually support Planned Parenthood through our breast and cervical cancer screening program.
Okay.
So we are reimbursing them for mammograms and pap tests. We haven't had those conversations per se, but we've got a relationship established, so we could get that information.
Okay.
And from our side, it's been more about working with them to be clear on what Medicaid payment can or cannot happen, because there were a lot of lawsuits at the time and it
Yeah.
went back and forth. So our discussions have been more along the lines of the reimbursement component and what they can or cannot bill for.
Okay. It would ask if either of the agencies can do a touch base. Maryland was able to do some things using their state dollars to help support to ensure that any of their patients that were seeking care can continue to do so in terms of all the range of other things that Planned Parenthood does other than abortion care. And it would just be helpful for us to make sure that they're still good as they're still here in the district. Okay. Was there anything that you guys desperately wanted to say on the record that we haven't talked
I'll
about
add
yet?
one thing, just to your WIC comments, because we finally have an MOU in place. We did kick off the data sharing of Medicaid data for WIC eligibility last year. It seemingly has gone off without a hitch. I don't think we have, I can't recall if you had data yet or not, but just tracking to see any impact. So hopefully we'll have just a more efficient way to help folks access resources.
Okay. Anything else?
If we had unlimited time and resources, you had talked about that preconception perinatal period, helping women enter pregnancy healthier. So how do we spend more time and effort encouraging woman visits? It's just, we have a limited amount of resources, but if we could spend more time on that preconception period and help women enter pregnancy healthier.
Yeah. If we had unlimited time and money for a variety of different things, that would definitely, there's so much that we could be doing, should be doing. There's so much that I wish on, the federal side that they were doing, like that conversation with Dr. Auguste around like, we need more research on preeclampsia. Well, it's not as though the District of Columbia can fund that type of research on its own. We really need NIH and our federal partners to step up there in terms of something that is so dangerous to the risk of the health of, a mommy and baby, but also, it's been going on for so long and it's so frustrating to be able to tell folks who are experiencing that, like, I don't know why. I can only help you manage through it. So anyway, this does conclude today's roundtable on maternal and infant health in the district. I want to thank all of you who participated today and for sharing your experiences and expertise. I very much look forward to DC Health getting their new dashboard up and running, because I think that will help a lot in terms of telling a a more up-to-date story about what the state of things are in the district, as opposed to waiting for these reports that are using old data and sometimes late. And I could have that conversation with the Office of the Chief Medical Examiner, as well as like the whole point of the Maternal Mortality Review Committee is to like dig deeper and find where the trends and connections, but like it is super unhelpful if we go 4 or 5 years without getting any data or information. And then when we do, it's 4 or 5 years old in terms of the work that we're trying to do. But overall, your perspectives are super critical to how we shape how the district responds, as are the public witnesses. And I want to thank them all again for being very vulnerable and sharing and being a part of this conversation. Written testimony will be accepted through Wednesday, July 22nd at 5 p.m. on the council's hearing management system site at dccouncil.gov/hearings. The committee will reconvene again next Monday, July 12th at 1:30. It's a joint hearing with the Committee on Public Works and Operations to talk about everyone's favorite neighborhood critters, rats. We will be discussing Bill 26-492, the Rodent Abatement and Transparency Amendment Act, the RAT Act that was introduced by Councilmember Lewis George, and Bill 26-707, the Rodent Education and Management Yields Results, the REMI Amendment Act that was introduced by myself along with some of my colleagues. So if folks are interested in talking rodents with us, I believe we will see DC Health there. And with that, the time is 2:52 and this roundtable is adjourned. Thank you.